preclinical preclinical lab. So the OSCE that's coming up is going to be the overall assessment for junior year clinic. So that's the, am I ready to be a senior or not? So, very serious. Please don't freak out, but take it very seriously. Okay? So, start thinking about discussing with your friends the periodontal diagnosis, the AAP system. What are the things that count for when you're looking for what is happening with this patient? MedComp, we're doing that as well. So you'll be doing a quiz, you'll be doing an interview with a patient, air quotes patient, standardized patient. Get your sleeping cycle in sync with school, Ms. Lennon, now that you're back from break. And eat well, be adequately but not overly caffeinated, you know, all those things. But think about all those things that we've learned over the last 3 quarters and the things you're seeing with patients in the next couple of weeks here, because this is where you're going to show me that you have pulled everything together and you've got a reasonable picture of how to assess patients. Okay? Modifications to treatment, you know, so there'll be a health history on your patient that you're treating, you know, that you're treatment planning in Axiom. And there's going to be the interview, there's going to be a little quiz, there'll be some pathology slides, not the crazy hard things, but some really easy, see them every day kind of lesions. Okay? So what kind of lesions do you see every day?
Linea alba.
Linea alba.
Tori. Tori.
Tori.
The tree one.
Fibromas.
Or you read Applaus, Wiener, Major, it's Cankisor, but
Abscess.
yeah,
Abscess ulcers. Anything else?
Mortification, buckarum.
Ooh, she can say it.
What'd you
You're
say?
ahead of me.
Repeat that.
Mortification, buckarum.
They chew the.
I
love it.
Right?
What was that?
And if you could spell it, woo!
Wow.
So, and then it's going to be, do you need a consult about this lesion or condition? And can you treat it today? Right? So it's going to be stuff you will have seen already on clinic, on your average patient. So,
Just be careful you don't get on your hands because
No
it's sticky. You're welcome.
so just, you know, be thinking about pulling all this together. As you're on clinic, be thinking about how's this patient, what is it about this patient that lets me kind of Ready? And let's say, start talking to your classmates. You're just going to pull it all together. You know more than you know. Figure that out and realize you can show me this stuff. Yes.
So like including like next visit.
Yes. What's their diagnosis? Right. What's the treatment plan for your diagnosis? And that could be prophy to referral to perio. You know, just know what can you do for them. You need more information about them before you can treat them. Can you treat them today? All those things that you're going to do when you assess a new patient every time. What's their recall going to be? Okay?
What's their category? What's their stage? What's their level of periodontal involvement? Attachment loss, that's a big thing. Does it all agree on the little sheet before we check in for assessment? That also, the better you get at that, the more proficient you become. That speeds up the process of getting all of your assessments checked. You know, that one tends to backlog us a lot, slow down. That streamlines.
Right? You know the cheat sheet on the back? You won't have that day. Okay, so you're gonna have that staging thing in your head.
Will we have the flag though, or no?
Yeah. Yeah, you'll have the,
Just not the little tree you're talking about,
or,
right?
yes,
Yeah.
yeah, so the, category, you won't have that little map
Yeah.
thing. The AP, you won't have that little notes, you need that in your head. Okay?
Yes.
And then also,
Good.
What page is that?
upon, everything that you
August
mentioned,
1st.
everything that you mentioned, and then everything from the last OSCE that we did.
And then
Could be
you're
correct.
also going to do the clinical, which is set up a chair, right? Set up a chair correctly. Vitals. EOIO. You're going to have the, in the morning we'll have the patient interview. So that's your final project for NICOM. And then the 2 injections. And that's going to be the same. It's going to be the half hour to get 2 done. Right, so that's why we practiced your last quarter. Okay? So, good. We can start chatting with the classmates. So, and I found out not everybody gets to be at the lecture about this, so we'll have to figure out how we can record it for people who will be at HIV training. Okay. But all the info, the PowerPoint and everything, of course, will be posted. So you'll have that. All right, plan of the day. As you can see, our objectives. We're going to just, I think, you're already kind of rebooted, seating positions, your light, your retraction, modified pen grasp, fulcrums, intraoral, extraoral, and we're going to talk again about those alternative fulcrums, the reinforced stuff we did last 2 quarters. Who has their loops? That's it, right? And you got it, excellent. Okay, so definitely start, because it is a steep learning curve for those guys. So it's very challenging. We're going to, like I say, talk about the finger assist and reinforced fulcrums. We're going to review all the instruments as we go through. So we're going to try to hit everything. Basically, you're going to, it's a little warm today. You're going to switch between instruments as we go through. I don't necessarily do that super formally, but you just hit everything as we go through so that you know what everything does. We did the 13-14 on the lower and upper interiors. We're going to talk about doing a little alternative fulcrum and direction with your stroke for those guys. And that is the plan. Okay, page 2. I gave you lots of room because I want you to write down seating positions for yourself. Very detailed. So that that's really firmly in your brain. Excellent. And then we're going to talk about some of the concepts of instrumentation, just touch on those again, so that you're into that. Okay, so let's first check everything in your cassettes for sharpness. Ah!
That's so nice.
Great. I wish you could do that to mine.
Oh. Yeah. I actually
You can
don't
borrow mine, Tish.
have my Mine's in my locker.
Really good here. Oh, there. So we talked a little bit about organizing your cassette last quarter. So really start thinking about getting an organizational system that works for you. And I tend to have my things in an order that I usually instrument. Left to right, because that's how my brain works. Oh, no, it's this.
What tightened this here?
Oh, the
This?
one of the black knobs. Oh wait.
Oh, yeah, this?
Yeah. Does it work?
No.
No. Oh, actually, that's the one in the very back. The silver one.
This?
If you go,
What tightened?
Trying to tighten the neck.
yeah.
This?
That's pretty tight. Or is that?
Yeah.
Let's let it go first.
Oh, here's the problem. See this little knob that's the neck? See how the neck's hanging onto that little knob, but this isn't screwed in all the way. So,
I can untighten it. Can I untighten it?
let's see if that's.
I can untighten this one.
Okay. There we go. So.
How did that happen?
Oh, they loosen up all the time. People crank down a bunch. Yes, it is.
Oh,
Okay. I need to switch those. Brace.
Oh, no, it's still not
so
good.
much. Should we find a remote chair?
Yeah, we can do that.
Just because this is too much of a hassle. Thank you.
Let's see if we can do this.
Oh, you did it. Oh, yeah.
Okay.
Okay, thank you.
Stick.
What is this? The gun. Oh. Basically, these go in a giant dishwasher,
Oh yeah.
so we'll try to,
Try to get this guy out.
yeah, I'll send that through.
This guy is gonna take some time to take off.
Okay,
Yeah. This.
just work on it before you turn it again.
Yeah. Oh, yeah, I have your question.
Okay. Go ahead. Yeah.
It's like the Explorer.
Okay.
So don't scale it. Just think about the graph. Yeah, so I would push lighter. Barely touch. Yes. Okay. Yeah. Sorry, it's hard to visualize.
So, okay, got
So
this.
towards you is okay, away, okay.
I'm saying this.
Because you can remember that. Yeah. So, side to side, level, yeah.
Okay.
No,
Oh, so focus on.
yeah, so it's one over. Fine, it's just, yeah.
You mind if I use that?
Yeah.
Thank you.
So, go ahead and turn your monitors on.
Okay. Maybe I should go to home. No, I like my spot so
It's your
much.
frustration.
I'll just share with them.
Sorry. You'll be able to see to the.
Yeah, I can see.
Do you want me to angle mine this way? Or probably that one?
The reason, yes, this one because the light shines better on it. But thank you.
Oh, okay.
Workstation.
Here, Trish.
It's okay, I agree with that.
Don't feel bad. Please don't feel bad.
Mine?
All three of those cassettes, you don't have one.
Yeah, they're in my, tackle box.
Don't feel
So-
bad because then I won't
They've got to be sterile,
feel bad to
yeah.
ask
and
you.
they have to be one per.
Okay.
So it's good.
Okay.
Okay, so sharpening. Tell me the difference between your sickles and your curettes.
Rounded tip
Yes.
versus pointy. So
And then rounded toe versus.
Yeah. Yep.
Oh, she said tip, sorry.
It's okay.
oh,
I thought you meant.
together, Trish.
All together now.
Tip, toe, you know.
Okay, so.
Can I use the purple one? Can I use the-
The important thing to remember is that we're doing the technique of keeping the face of the blade parallel to the floor or countertop so that you can really visualize the edge and that every single instrument has that same internal angle. So since you're all ready, your stone's going to be at what clock position?
3?
1 o'clock.
1 o'clock.
1 o'clock. 1 o'clock.
So
Yes, 1 o'clock.
flat, you know, to parallel to the floor, open that stone out to 1 o'clock. Usually way easier to point the toe towards you for the one side, the toe away from you for the other side. Universal curettes and sickles, how many cutting edges?
2 cutting edges
2 cutting edges per end.
per
right?
end.
Terminal shank compared to the face of the blade. On a universal thread or a sickle. Face of the blade parallel to the floor, the
Parallel.
terminal shank is going to be what to the face of the blade?
Oh, like the degrees?
Yeah.
70?
Hold it up, hold it
90.
universal. Yes. Okay, it's a universal thread or a sickle because you can lean this way for this cutting edge, you can lean that way for that cutting edge, right?
Correct.
So, if you're trying to get the face of the blade parallel to the floor, then you can have your terminal shank help you to say, oh, is this face of the blade parallel to the floor? Okay, Gracie's,
Mm-hmm.
what's different?
One,
They have a longer,
One cutting edge.
one cutting edge.
And so I heard somebody over here say,
oh, I was thinking
one
same
edge
thing.
is what?
70 degrees?
Lower.
Lower.
Oh, longer. Longer.
Well, it's our little mnemonic.
Oh yeah, LOL.
Right? So lower, outer, longer curve is the cutting edge that you're working with.
Correct.
And so that's what you're sharpening. That is the only cutting edge you're sharpening,
Mm.
right? Because in the book it says it's the working cutting edge. Okay. So, when you're holding the instrument, we want to use palm thumb grasp. So that's the lovely picture of my hand in the upper right. Because you want that super duper stable,
Yes.
right?
Mm-hmm.
And what are the 2 pictures underneath that show?
Should be palm.
Oh yes.
So you're going to hold that parallel to the floor like you're holding a little spoon of liquid, and if you look really, really close to the left-hand picture, it has a little tiny drop sitting on top of the blade. Okay, so the other thing about Gracie's, besides lower, outer, longer, is the face of the blade is going to be what compared to the floor? When you're sharpening. While you're sharpening.
It at an angle.
The face of the blade.
Like the face of the blade is like.
While you're sharpening, the face of the blade is going to be what?
I'm kind of greasy here.
Parallel to the floor.
Parallel.
Oh, okay.
Oh well, not really.
Okay, make sure it's parallel to the floor. Can you use your terminal shank to help you with that? Not so much, because lower, right? So, I don't pay so much attention to my terminal shank. Because it's going to fool you on the Gracies. All right. Also on your Gracies, on your universal turrets and your sickles, because they have a curve to them, you have to go across the surface of the cutting edge when you're sharpening by rolling your sharpening stone. Right? We're starting in the heel, we're finishing up on the side of the toe. Gracie's, remember, you're going to have to roll more to get around that curve because it's even curvier. Okay, so what's that lower right picture showing?
How to test for the hooking yourself?
Yes, please, 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 don't poke yourself. Okay, so making sure that you can have a finger up there to stand up so that you're able to, so you're able to adapt the instrument that you're sharpening. Sorry, the caffeine's going to kick in any minute. That you can adapt your instrument just like you would to that tooth, right? You're going to think of it as a distal, mesial, whatever, so that you're checking.
Come again?
Slow down a little bit with your sharpening so you don't get yourself.
Oh, okay.
Okay. Okay. So we talked about face of the blade. We talked about how curvy the two things are. The thing I left out because I ran out of room and then I forgot about it is, how about the toe of the Kira? What are we going to do with that?
3 o'clock?
The toe points to 3 o'clock. That end of the blade is going to be really flat, parallel to the floor. And then your stone position is what? 2 o'clock instead of 1. So remember that you're opening that up. Okay. And then I'm really going to strongly recommend, I'm just telling you, do the sides of the cutting edges and then separately do your toe. So you'll see us go all the way around the toe. Don't do that. You're not ready yet.
Okay. So
Okay.
just do that, and that?
Do, because the
That's such good
angulation
advice,
is
too.
different.
You know, I love what you just said. Even in private practice, I would stick to that advice because it's too often. I've even seen it in myself. We get doing this, and before long, we have Grayson stickles. It's true, right? So that's such a good thing right now. I think start getting in the habit, and then stop, and then do your toes separate.
Yeah.
It's too easy. I've seen it professionally and myself. Okay,
In
so I think
private
that's a
practice.
habit. If you start now, your instruments will stay in better shape longer
Okay.
and be appropriately, will be the right sharpness. Great advice.
I'm going to tell you, your self-assessment is going to be really important always because you're always going to be improving. And also you will always fall here and there into little habits that aren't great. So there are times I picked up an instrument and really looked at it and gone, oh my God.
So true.
Who shortened this? Oh, that was me.
Scary.
How I let this get so thin? Wow, that's a weird angle. And it'll be like one particular instrument, one particular cutting edge. I'm hearing good sound tonight, hearing any little flicking on the downstroke at the end. I'm super excited about that. Good job, guys. Okay, and then in the book, because I know y'all did the reading last night.
Actually tried.
Good.
I tried.
It was good.
I did a
'cause,
couple.
Oh my gosh, we were here forever. Sorry.
Yes. I did a couple.
Lucille and I party in the clinic 6 p.m.
Yeah.
She and
You guys
Cindy
missed out. You guys missed out.
Right. She and Cindy both had to do x-rays, full data on current patients.
Oh.
Woo, we had a good time.
Man.
Okay. The picture, we are going to work on sharpening files today, cautiously. The picture in the book has the stone at this bizarre angle that would dull everything, so that's why I have a little note saying, please don't look at that. And I have this picture instead. Okay, how are we doing? Things getting sharper?
Yes.
Good. Why did I let him get this dull? Right? I'm making myself work harder.
Because sometimes we get lazy to sharpen.
I was exhausted by the end of last quarter, Ms. Lennon, that's why. Yes, I understand. So were we. There you go.
So that's good. That'll sharpen your light, your focus. Yeah, so you can always see where your blade is,
Yeah.
and where your cutting edge is with Gracie.
if you're looking at your test kit today and it's like, oh my gosh, this thing's all chopped up. They're cheap. You get a new one.
That's a good sign. So listen to me.
Okay.
How did I fit all those tools in here?
Instruments.
Tools. Tools, instruments. How did I fit all these instruments in here? Oh my goodness. I must have added something. Okay. Do you mind if I use the... Yes, thank you. Okay. Oh, this one's really thin.
Mini Gracie's are SAS, right?
Yes.
Just want to make sure.
Is this really thin? Is this too thin for my... I think I overdid my run.
Yeah, it's pretty thin.
Okay, be careful.
And it's also short. Just a little bit. See, compared to this end. I'm gonna say.
Okay.
So,
13, 14. I got it now. I don't even remember using it that much.
could use it for a protein.
Okay.
Although the one is going to be a little fat. Then don't push too hard when you're testing.
Ms. Bonner, are you wanting the seating position, like supine, supine, or away or towards?
Yes.
You want both? Okay.
Yes, it is. That's all of that.
Okay.
Would you happen to have an extra pen upstairs?
A pen?
Yeah. Oh, thank you. upper right.
Yeah.
Wait, isn't it? Is it the maxillary to be supine? Or and then the mandible semisupine? It is. Okay. So after two words, yeah, I would say away. So the patient is. Oh. I don't get what it means. Oh, it's it. Yeah. And then, do chin up to it. Chin up to it. Close the chin down. I think it's chin up.
Yeah.
It'll be the one. So it'll basically, okay. Cool.
Oops, sorry.
Oh, don't be. It's my fault.
I got it.
Some people lost their time.
Oh, yeah.
AJ came in for like 10 times.
Here, take mine. So that was the word. And the only difference with that was just the word and then. I think it might change that. Maybe 11 o'clock? But then, yeah. Or try 9 o'clock.
Just have a question. Maybe we got reading something designation.
Oh.
They open at it first, since I'm working, do you? Well,
Yeah.
so you can see better.
So if there is somebody who's really struggling to keep your mouth open, use a bike lock. Okay?
Bye, flop.
Yeah, you want to be there. And the other thing, the other trait is patient, you can play the chair.
Because that was the
Support, always position. Your lighting, you know.
Yeah.
That makes your appointment so much longer than more life.
Okay.
That's it.
Cool.
Have y'all used a bike lock?
When you do that,
Okay.
I have.
So what's the super important thing about using a bike lock?
Make sure it doesn't go down their throat.
Right? So how do you make sure it doesn't go down their throat?
You put a flossing in.
Floss on.
Floss.
So it comes with a little hole. So you've got to put floss through it. And what's the deal about the floss?
It holds it in place? Oh. Tie it?
Drop it because he has to get something from
Don't tie it.
none of your business down.
Don't tie it. Because that wax floss is going to untie itself. So, I'll show you.
And it won't come off?
So so growing up in the 70s, in the 60s and 70s, macrame, you do a little macrame knot through it.
Oh.
So it's one continuous piece that you wrap through. So you take a pretty long piece of floss, you put the ends together, you take a little, fold it over the middle of it, you put that through the hole to make a loop. You go through the loop and you grab the two long ends and pull them through. It has no knot in it. So we'll get one. Y'all can practice.
Cool.
He closed them out.
It gets exhausting
Oh, yeah.
staying open for your 4-hour appointment, right? But here's the thing with the bike lock. Also, So they can drown, basically, you know, because they can't close their mouth, so they have a hard time swallowing. So you have to be good at getting it in and out of the mouth. So before you leave today, we'll try to do that. So in the clinic, they have them probably notify that.
And go grab it. I know, I saw it. It's a white one. White
Yes.
plastic.
Go do that. And then,
Thank you, Sarah.
Wherever they're at.
Okay. So a couple of aspects to wear. I feel like there would be.
In the right one.
Oh, I see that.
I don't want them to get any thinner.
so if you ruin an instrument, which you will, right, or you just wear it out,
Yeah.
then keep it, you know, get it sterile. And then when it next comes through sterilization, you open that cassette, set it aside. Because you'll do an instrument swap next year, that you'll be able to turn it in for a deal on a new instrument.
And it's cheaper to get it right now, right?
And while you're in school, they're cheaper.
Yeah. But when we go to the office, we don't use our own instruments?
They should be supplying you with instruments.
Okay. So these are just stay safe.
Yeah. Yes. That would be part of your, do I want to work here?
Yeah.
Or not?
Yeah.
If they say, well, you know, we think instruments last for 2 or 3 years, you can say, you know, bye-bye, Felicia.
Yep. Bye, Felicia.
So, yeah, it's a matter of thinking yourself. That was deal with the place that I worked at, that they stopped buying me instruments because I was going through too many instruments. Let me think, who was seeing all the root planing patients? All the hardest root planing patients.
Mercy.
I had another former boss who said, let's be realistic, you know. If you had to, you could scale with a Craftsman screwdriver. Yeah. I also had the no you didn't face. My other response was, and I managed to keep it within my lips and not have it fall out of my face, is get in the chair.
Yep. Let's try that on then.
Let's start with you.
I'll show you how that goes.
Yeah, I'm gonna have to, I bookmarked it, I'm gonna have to send you guys a link to an article about it.
You know, that's actually one thing I would like to know a little bit more of, is like how to, maybe this is weird, but how to stand up for yourself in the office. You know, like what are some proper things you should watch out for that you may be taken advantage of, or like, or...
That will happen in special topics
Oh, okay, great.
class. Special topics.
Special topics.
So,
It'll happen.
resume, how to go find a job, what you should expect.
Yes.
A lot easier. But
I mean, I just know how they treat dental assistants. If you don't know your rights, you could get played.
Yep.
And so I don't want to.
Yep. You talk about tax law in that class.
Oh, okay, that's awesome.
So anybody works in an office that the hygienists were independent contractors?
No.
What does that mean?
Illegal.
Yes.
Oh. In other words.
So that they are paying you as if you're an independent contractor when you're totally under their control because they make the appointments for the patients. You're using their equipment. They set all the appointment times. And
Just so they don't play.
withhold it for you. Yeah.
And you just
Yeah,
come
a lot
in.
of benefits, but no withholding.
Yeah.
So you basically are taking on your self-employment tax, which is crazy.
Oh no.
I don't mind self-employment as well. And have all the benefits. Self-employment, if you know how to do it.
I'm having a hard time with this one. Oh, you use the pink side. I'm scared to use the pink
Right.
side.
So now that you're seeing some patients that are a little harder, you can use the pink side of the stone cautiously to be able to.
Light block.
Thank you.
Light block.
Oh, thank you. I see the hole that we were talking about.
Mm-hmm. It's not coming to life.
Okay, so now you can demo. Lots of light blocks for all of them, so they can see how to use it.
Okay,
All right, guys, give her your attention.
come on around.
Come around, check out Lennon.
I'm having problems with this one.
Not this. This.
Oh.
Okay.
12 inches.
It's the middle. Come on over. See.
Wait, what? That was too fast.
Well, that was hard. Do it again.
Okay, I know you put the loop through. Okay, that's in the middle.
It's like,
Okay. Alright, I got it.
Okay. Notice I didn't describe it to you. You actually learned better that way.
And it goes like this.
Yeah.
So the wider side goes to the outside.
Oh, I know.
Okay. How big does it have to be? It has to be big enough so that they're open wide enough, right? But a tiny person, they can only open so wide. It has to be small enough that they can open reasonably comfortably without like having to be a snake and disjoint their jaw to get it out and in. Okay? So if it's too small, every time they move, it'll pop out and it'll fall in their mouth. If it's too big, they're just going to be dying if they try to, if they start to choke, trying to get that thing out so that they can protect their airway is a challenge.
They
Okay?
have 3 different sizes.
Yes.
Yes, they have clinic. We saw they have the pedo, and then they have the standard clinics.
Thank you.
And
You guys go.
then, was the process just so that we could it's easier for us to.
Just so you can go like that.
They start choking.
Oh, you mean, oh, you.
Don't really like a salmon, right? Like, God forbid they start to choke and it's in the back of their throat,
Yeah.
you can easily grab it. So
Yeah.
that needs to be
Instead of having
long
to-
enough that you can easily grab it. Okay?
That's
So,
hilarious.
small intervention there. All right. So,
Miss Lennon? Miss Lennon? This instrument, I'm having a little bit of trouble on this one.
Oh, yes.
Your acrylic stick?
Yeah, we are sharing a
okay.
stick. Yeah. I can go run and grab mine, actually.
You want to go get your acrylic?
So this one
Yeah,
is
I'll go run and
fine.
grab
Close
it.
by?
think about it being
It's
easy.
just upstairs.
There you go.
Oh, maybe
Well,
I'm
when
not.
she's done,
Oh,
it's okay,
maybe
I'm
I'm
gonna
not
start
tapping it
down here.
right.
Oh,
Stay
okay.
where you're
This,
at.
okay.
Okay.
There
I
you
got
go.
that one. This one here. Oh, let me try this one. Measle. Okay, so sharpen it.
One last question you have to ask.
Oh, yep, that's right.
Those little guys, they're hard.
I forgot about this one. The 1112.
That's for anterior, yes?
The 1112? It's for the measle.
The mini braces.
Yeah. Inferior.
Not for anterior? Sure.
Yeah.
Oh, I actually thought the floss was in here for some reason.
And then those are disposable, by the way.
Oh, they are.
Yeah, I thought you could sterilize.
No. Yeah, these are all disposable, guys. Don't sterilize them.
Have it melting everywhere, all on your instruments.
Some of them are more rubbery. Now that they're disposable.
I would expect for them to leave and fill
That's a tight bun, Trish. You got your hair really all in there. How'd you get that?
I just twist it. It's because I straightened my hair,
Uh-huh.
so it's like kind of,
Oh, so it's easier to be, yeah.
yeah.
You just, yeah. Put that all in there. You look,
I was gonna have you braid
It's
my
nice.
hair the other day, but
oh.
you were tired and we didn't get a break.
Uh-huh.
Hopefully you can do my hair too.
Oh, I have a style for you.
Yeah?
I think Brian should do a fade.
Yeah.
Fade?
You look on
Yeah.
point.
Oh, you
Yeah.
can hold it down.
You should.
I already had a picture for you.
You using the yellow thing?
No, that's just a cover.
I have a beard now.
No, I'm taking it off.
Why? It looks good.
I don't like
I like
it.
it.
I just left my trimmer at home.
And he doesn't want to buy
It
one.
looks well groomed.
I don't like it. Go fast. Go too fast.
Let me show
So,
you.
so what is a fade?
Yeah, I'm gonna show
Fade
you.
is a fade when you go to the side and it fades higher.
Oh, I see.
The sides are shorter.
Play love.
I did it.
Great job.
Good job, Brian, man. You know how to go at the time.
Now to tie my shoes.
Yeah.
Oh, dang.
A fade.
So I can go up to like a barber and
Ask him to do. He'll know what to do.
doesn't know what to do?
Yeah.
Okay. I think Noe does that too.
So nice.
I'll ask him where he goes.
But you again, ask him yeah.
Okay.
You look so good.
Really?
Yeah.
Thank you.
Yeah. You have nice thick. You have a lot of nice hair
Oh.
on top.
Oh
You
yeah.
have a lot of nice hair.
I do
use
need a
it-
haircut.
No, while you still have it.
Oh. Yeah.
I mean, I don't know if you'll ever get bald, but you know, I don't know if it's in your genes, but.
Oh. Well, my hair will get thinner.
Okay.
For sure, 'cause my
Well,
dad.
use, if you have it right now, yeah.
Just take advantage
Take
of it.
advantage of it.
Alright.
Yeah, I want him to get a fade.
Yeah. Oh,
They kind of cut it here, but they kind of have hair, like kind of like his hair, but his is kind of grown out.
it's kind of like shorter on the sides, but they like go. They,
Yeah.
They fade up.
They kind of fade up here, and then you still have the top hair
Okay.
still going.
Okay. All right.
It's yeah. I'm telling
They
you.
want me to be GQ. All right.
I'm trying to find someone I can learn.
Forget what's called.
Paula's the one. Paula's taking it.
Well, if I would have had my
It
speech,
would have been easier, but I lost. Well,
actually, the most important thing is it'll become like your least favorite. You have to do it.
Okay, did each of you identify, have any aha moments in sharpening?
Yes.
I feel like the loops work pretty well. For
Right.
sharpening. Yeah.
Oh yeah. It helps a lot.
That helps a lot, yeah. Because you can really see the blade.
I would say in the beginning, I wouldn't put you in loops day one because, oh my gosh, you'll slash your fingers because you can see less,
Yeah, that's true.
diameter.
Is this your first time using a loop?
Second
So
day.
when you're doing your 13,
That's the best.
14, or your, especially the 13, 14 or the 3, 4, that this cutting edge is pretty easy. When your toes pointing towards you, that's not bad, right? But if you tilt your toe up a little bit, it helps you get inside that elbow. Knee, elbow, whichever works for you. And then the toe away from you on the inside, that little inside cutting edge. Same thing, kick that toe up and bring your instrument your instrument this way, stone that way. And then you can be inside that angle without running into your handle.
Oh.
So I had the two parallel when she just turned it. I was like, oh.
Great. So I finally thought about a couple weeks ago, I was thinking of this analogy. So y'all can tie your shoelaces, right?
I learned today how to
You can tie your shoelaces in the dark, yes? Mm-hmm. Can you teach somebody else how to tie their shoelaces? Anybody tried to teach somebody?
Yeah, kids.
Right?
Make it bunny ear.
How hard was it to teach
Very
them? Right? Because you can literally do it unconsciously. Right? I don't think about that. In fact, if you think about it too hard, sometimes it's like, wait, I can't do it. So that's the same thing with this. So the stuff that we have automated as experienced clinicians, we forget to tell you because we don't think about it. So that is the thing about teaching, is being able to break it down to those little details, so without overwhelming you, too. Okay, so thinking about getting your instrument angled, you've got your testing is feeling more comfortable, you're accurately testing to see if you're good. Okay, all right. And yeah, we're at an hour.
Yay!
Please come,
hour
please come with
down.
sharp instruments. And, right, remember how we did this last quarter? So, take a break, because do the bio break. Move around, clear your brains, and 5 minutes max. Come on back, we'll get into the position and stuff, okay?
Cool.
And if you still have issues with some of the instruments, we switch, take a few moments to sharpen it if you need to.
I'm gonna hire Paula to sharpen my instrument. I don't want to do it. It's not my favorite thing, but she does a nice job.
I thought you was in
You got me. Almost necessary.
Lunch hour, I showed up. 3 or 4. Oh, yeah, my first day there was so stressful. But, oh, this is not. They do. Well, we use that for surgery. They said, you use it on surgery because they're heavy. What do you think I'm doing in here? It's the same place where, right? It was 1985. What? Which that is really hardship with my car. It was just a lot of money. So, yeah, this is, the summer was 85. I had pictures of the summer treatment last. Why different routes. And you know, best practice at that point was Remax. The dentist had gone to visit him in the hospital. Recovery. Never came back and wrote in the chart. So you treated him without Remax. And nobody asked her. Just 1965. You better yeah, it was just insane. I lasted there a year. I actually did this. Oh, okay.
Okay.
Okay. I told her to come there too.
I don't know what's going on, but we're getting these things a lot. All of a sudden. It's like it's free yesterday, first week Wednesday, I get Wednesday.
Well, I guess always that race or.
So do you want me to start here or start?
You can start on this one.
Okay.
I'm taking the monitor. So the best thing since the cable is what I do is this one will be easy. So I use this one to fish it through. Yeah, but before you do that, I'll show you. You have a this way first and do this. So while I'll pull this other one, sliding the other one.
So do you have a place up here?
I stay in the car.
You live where?
I know. It is pretty cold in here. I don't know why. I think it's just like a habit. I don't know how I do that.
One of them,
In the
my husband.
Have you gotten it? Oh, you're probably
you go up to the mountains.
Yeah.
Yeah.
He's the one that takes you.
My husband's sixth grade. Let me see. My husband's sixth grade.
Oh, yeah.
So little horses. Oh, huge. Yeah.
So you guys are gonna be working on this?
He's going to be working for our business. We used to work there taking care of the horses. But I said, I'm not doing that because it was way too much work. And I'm here Monday through Friday. So he's working, she owns a silicone business. They sell to Disneyland, Universal Studios,
Yeah.
big contracts. So he's doing that and helping out her on the ranch, but she matched his mechanics pay. So he's not losing anything. And then she can't live there because she's only charging us $6.20 for utilities. Yeah, and then she's just taking the rent out of his check.
Oh.
So we pay less tax.
Do you have, you just have a
Yeah. Oh, I'm gonna stay there at least a year and save.
I told them I wanted to buy
She wanted to build us a house like to add on to it. We're like, let's see how it goes. Yeah.
No, I think, I mean, I'm gonna see if I like.
I'm excited. I'm just tired.
If I like this.
And there's like so many things coming up we want to go to.
It's okay, girl. We can't do everything. Boundaries. Boundaries.
Oh, they're pretty cool. I like them.
No, do not forget.
Hannah's going to do more things than I am.
Let's see if I get used to this.
She got the last of that.
I was there for the CB.
I know.
It's not healthy.
That's like, yeah. That's like too much.
Yeah.
This one.
I know.
That's excessive. You're out.
I was like, I was looking forward to
2.5.
Yeah.
That was just the sales guy was saying, oh, that's probably better, but
Look at how
I know.
that's the point. You put yourself out there.
Yeah. And now you want to
Now you want to
that's
and
what
hang?
the strap.
No.
I'm gonna try it. I spoke to the guy.
And that was your
and
choice.
I'm gonna see if those are better.
And it's not like you have any friends.
Oh, you did? Yeah. I think so. Possibly.
This is a lot of wrong things with that. That I was like, okay,
2.5 scale.
2.5.
okay, we've gone too far.
Yeah. So the lenses are better, the field of vision is better with the 3 than it used to be. If you're talking 5, you're looking at a tooth, right? If you're talking 3, it's a little constricted. I would still not ever do local anesthesia with loops on.
With what?
Loops with
Oh,
anesthesia.
yeah.
Nobody
wanna
needs
do-
the
not a
Maryland
good
piercing
idea.
from you. Okay,
We don't want to do
Wait,
Botox.
so
right?
what did you say about 3? Do you recommend it or no?
I think 2.5 is good.
They'll use the other.
Like I was saying, the way they design the lenses, you have a wider field of vision than you used to have with some of them. So you have to be cautious about that. How much of this can I see? So I'm not gonna, take my 3A and thrust it through their lip on my way into the mouth. So, are you noticing already that you have to, as you're approaching the mouth,
Yeah.
look over the top
Pretty
or a little to the side, right?
Oh, yeah.
To get in. So, when you're using your loops, you know how I talked about direct vision versus indirect vision, so that your overall, and we're going to look at it positioning right now, your overall positioning and everything you set up, and you get your hand, your non-dominant hand in there to retract and be able to see. And you do your direct vision to get to the get ready zone, and then you're going to use your indirect vision as needed to actually adapt to the tube. Same thing with your loops. So you're going to look around or over your loops, whatever will not tweak your neck, get in the mouth, and then as you do your final adaptation, you'll look through the loops. So that's why it's a learning curve. Okay, so positioning. Right? This limited is I just have to hurry, so I just can't sit in a good place. And then you go home and think, I feel 80 years old, right? You're young. You maybe don't feel that way. You will. Sorry. So, the ice pick scab pain right between my spine and my scapula on my right side, that was year 3. Yeah. I do not want that to happen to you all. So, we're going to review again in detail, and you're going to take notes on positioning. So have a ready implement out, and we're going to, as we go through all the different spots, you're going to switch through instruments, and you're going to take notes about what works for you as far as specific technique and positioning. Okay, modified paint graph. If your graph does not look like this, I know I said it last quarter, but if your graph doesn't look like this, we got to fix it today. Okay? So, the picture of the electric drill. We call this a chuck grasp. Those 3 metal fingers that come and grab the drill bit to stabilize it are called the chuck. Or if you're being formal, Charles. So, are you awake? Okay, good. Okay. The cold is keeping us awake. So that's going to be the, it doesn't twist and such. But we also then need lateral stability because we need to do some forceful things by rocking against the tube. So having that index finger cocked back 90 degrees, having the thumb on there so that you can push and pull with your thumb to roll the instrument in your hand is very important. So we're going to look at the triangle forces of the upper right picture of my hand around the handle. If you're still struggling with that, I gave you all the triangular pencils, yes?
Yeah.
Yes.
Get out that pencil, walk around with it in your hand some more. It doesn't roll, but it does get you on the 3 sides of the triangle on the handle. And then I'm making myself a nice teeter-totter with my middle finger, which is stacked on top of my ring finger, which is on my fulcrum, compared to where my index finger and my thumb are. And that space in between my middle finger and my thumb and index finger, that's my lever. So if you scrunch up too much, you're going to lose your leverage. So remember, your handle needs to go usually between the second and third knuckles. And your index finger and thumb should be across from each other. Why are those two notes on the same slide? Try sticking your thumb too low on your handle. What just happened to your handle?
It went back down.
It went into the V, right?
Yeah.
Oh, yeah.
Are you stable holding it that way? No. See how I'm kind of on the side of my thumb? And my thumbnail's blanched because I'm desperately trying to hold on to this sucker to try to not have it fall out of my hand. And my index finger is hyperextended a little bit. So if I didn't have the arthritis kind of holding it straight, it would be hyperextended really bad right now. And that's one of the reasons I have the arthritis probably in that finger. So it's all over now. So it's just the genetics too. But making sure that your index finger and your thumb are almost straight across from each other, and your thumb can be a little lower than your index finger. Okay, so this is why you're going to have that finger cocked back 90 degrees. You've got to get all those fingers, all of them are working. In the book it says you should be touching your handle with your middle finger very lightly, that you should be able to take your middle finger off and still maintain a grasp.
Whoa.
No. That's a no.
No.
I'm sorry. Your instrument will fall on the floor or you'll be totally ineffective. If you don't have your thumb and your index finger, especially your thumb, pushing that handle quite firmly onto your middle finger if you're doing anything forceful at all. Okay? I don't know who wrote that. I'd like to have a conversation with them. But I have considered it before.
Oh.
So, having that space is really important, and having all of your fingers engaged in your grasp is really critical. So, that tripod goes both ways. It's around the handle, but it's also that extension, that leverage between your middle finger and your thumb. Got to hang on to those guys, because this is what's going to stabilize the instrument. And it's the teeter-totter. So you don't want to go crazy. This is a little too far maybe on my upper right picture. But if you're scrunched up into a little ball, see how there's almost no distance between my thumb and middle finger on that lower right picture? And I have to be all curled up. And this is when you get into the little pick, 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 pick. And you can't have, you just can't get strength that way. Okay. So, you see the bigger kids on the left side of the teeter-totter? That's the calculus. The littler kid is on the right side. So why is the fulcrum where it is? Compared to leverage
To bring up the,
right? The whole idea of a lever is if you are on the long end of the lever, you're more powerful.
That's right.
Right? That long lever is what is giving you the ability to do greater work. And so if you scrunch way up, you're giving up your advantage. Okay, let's see if we can. So this, when we talk about the fulcrum,
You mean like range of motion?
so right here, see how this is actually where the power of the fulcrum is coming from, right? Fulcrum, ring finger, middle finger, handle stacked on top. And then pushing the direction I need to with my thumb and index finger. That is this part of the, so not bunched up, but that is the longer distance between that log and the smaller kid. The big kid's the captain. Does that make sense?
Yes.
Okay. All right. Choosing the right end. So, you're in a, oh my gosh, it's 4:10 and I'm supposed to be done by 4:15 and whoa, this luggage breathing down my neck. So, let me explore really quick. Okay. It's easy to slip into with your Universal or with your 11-12 Explorer. It's nicely wrapped against lower interiors of the Classic. So you can see Ms. Lee with the Explorer standing up super tall. She's got the terminal shank parallel with
The long axis of the tooth.
the long nexus of the tooth, and really specifically the surface she's exploring, right? And that toe, the heel is facing towards us and away from the tooth slightly, and the toe is then going to extend across. If you're using, especially like the 13-14 on a Profi, oh, it wraps so nicely in here. But think about the face of the blade right now. What angle is that to the surface of the tooth?
Away.
This
You mean
is
the
actually,
the one Miss Lee is on?
no, this
the
one on the right-hand side.
That one? Oh, okay.
It's too what? Too closed, right? So that face of the blade is probably at a 40 degree angle to the face, to the tooth surface. And oh my gosh, that's the recipe for burnishing. All right, terminal shank, Gracie's versus universal sickles. Okay, so think about the terminal shank compared to the face of the blade. Gracie's are already angled at 70 degrees, right? So your terminal shank can be quite parallel to the surface that you're working on. On the universals or sickles and Langer, which is a universal, you gotta lean to engage the two blades. Okay, so it's not gonna be parallel with the long axis of the tooth or the surface. You gotta tuck it in a little bit to get your 70 degrees. So that's 70 to 80 degrees, you can see there. So here's the other thing. Look at where the heel of the instrument is on that bottom picture compared to the tooth. It's out, away from the tooth a little bit. Why?
So the blade could contact the tooth.
So the side of the toe can contact the tooth. So when you look at this guy, the lower left, you got to have that heel kicked away from the tooth a little bit. Don't go crazy and make a big laceration in the tissue, but you've got to have it kicked out a little bit so that you know you're on the side of your toe. So remember we talked about you have to have the visual clues supragingivally to know what you're doing subgingivally. Okay, so again, upper right picture, the face of that blade is really flat, and the reason is we're on the wrong end, and we can tell that because what is that terminal shank do? Picture on the upper right. It's wrapped across the tooth. It's not parallel. Okay? So the picture on the lower right, there's a terminal shank that's going up and over. Right? So it's easier in the posterior for you guys to visualize that. Anteriors are more challenging. Okay, so if you need to go back to the default of, let me go to the midline and then try to figure it out from there, right? Right, so the V points to what? Back of the throat. So if you need to and you're not sure, okay, what just happened here, you can go back to the first molar in that quad you're working in and be able to just double check. Okay, tell me about the picture on the upper left. How's that person doing adapting? Not good. Too what?
Too angled.
Yes.
Too flat, right? Too angled,
Wrap
right?
it around the tooth.
See how we keep saying stand up on your fulcrum?
That's right.
And this is, oh my gosh, the two fingers are folded over each other and they're like on the facial instead of on the incisal edge. Okay? So, they're too flat. And whatever is happening, there's the terminal shank is just at the end of their middle finger. And see how that's not related at all to the long axis of the tooth, the surface they're working on. So think about, grab your sickle for a second. Have your eyewear on. And take that sickle and adapt, sit at 12. adapt that sickle with your hand way down and out like that.
Oh, like they're doing?
Do a bad job for me
Okay.
for a second.
Oh, back. Oh, yeah.
So what's happening with that leg?
You're like, yeah, you're not even adapting again. You're just like on the
Can
top.
you even get it interproximal really?
No.
Lingual or facial?
Well,
Come back here as well. Just gonna, look at that picture. So imagine that it's your friend in the chair, and then there's a patella,
ooh. That's gonna be nice.
right?
It's gonna be ripped up.
Okay, so this is why we keep saying stand up, stand up, stand up, right? Okay. This is the Venus de Milo. Does anybody know the Venus de Milo? No. Okay, no more classics in education anymore. So this is in the Louvre. I could live in the Louvre for possibly 4 or 5 years. I was an art major before I had school.
Oh, no.
I just saw her a few weeks ago.
Right? Like, oh my God, that's the actual Venus de Milo right here. I walked into the Vatican when we got to go to Italy and just like lost it. So, my husband's blind, I'm describing things that I'm just like, I'm just so choked up that I'm here. I can't believe this. The Pietà, right? Yeah. It's awesome.
That's cute.
Claire got a t-shirt of the Mona Lisa at the Louvre dabbing. She has a dabbing Mona Lisa shirt.
Okay, what is the point of this? Oh, by the way, that's my sister behind the Venus de Milo. My younger sister, Kathy. All right. Only I have that awesome moment and then think, oh. So, but I have to say, Anna Pattison, my senior clinic advisor, world-renowned advanced instrumentation specialist, said to us in school, okay, so molars are kind of like a woman's figure, right? You see J waist and then you have kind of a little booty, and we all went, oh. So, yeah, I went there with the picture, sorry. Okay, but here's the thing. What did we start with when we were figuring out where to sit and all that? Remember that little chart that you can recite? So,
Oh, like,
stick position,
yes, patient, like
me,
my mirror.
right? Okay. So that's the cookbook starts, because we're trying to start you in the bunny ears of trying to tie your shoelaces, right? Okay. But we want to actually adapt the terminal shank parallel to the long axis of the tooth, right? Also the cookbook answer. So look at the tooth anatomy. Okay? All those red line segments, you have to change your terminal shank to match them as you work on this tooth, on each of those surfaces. All right? So it starts with what? If you have a deep pocket that's subgingival that you can't see in the mouth. What's your superpower?
Oh, exploring?
What's your superpower?
Tactile sensitivity? Oh, x-rays.
X-ray vision. You have X-ray vision, right? Use it and evaluate ahead of time, but then you're also going to explore, probe thoughtfully. This is posted, by the way, too. So that you can, as you're probing, think about when you're probing. Oh, that was Miriam. She's not here today. Okay. So you got to adapt your probe down those surfaces to be able to detect the pockets to start with. Okay. So making sure you have adequate imaging, and that you are looking at it first. So I've had people check in with me in previous quarters where they open up the patient chart and they're like, so this is happening. And it's like, okay, but open your x-rays and you're going to go, oh, well, I'm not sure what to do with this patient. You know, I'm not sure what to do with this patient. Everybody look at me. I'm not sure what to do with this. Okay, open the x-rays, get your imaging, take a look before you, just like you're going to review their health history before you sit them in the chair, because you don't want to discover all of their things when you're talking to them 2 hours later, you're still doing the health history. Okay, so experienced clinicians, I think I did talk about this last quarter. You figure out what in this gigantic tray of instruments can touch that spot. What angle do I have to be to touch that spot and do an effective stroke? And so you start at the particular problem, because not everybody's like you're typing on, and then you're going to work from the inside out. So we started working on the outside in because you had no map and you had no idea what you're doing. We did the bunny ears thing. And now we're going to start at the problem, and wherever that instrument they can touch that spot because of the accessibility of the pocket or whatever is happening, that's going to put the handle of that instrument in a particular position, right? And then you're going to have to figure out where on that handle can you grab it and get a fulcrum to activate a stroke. And that means, because remember I said before, don't forget, Ms. Friesen would say, don't forget that your wrist is attached to your booty, right? So wherever your hand has to be, then your body has to follow. Correct. Right? So we're going to start, you've got to start thinking about that as seniors. It's time. Yes, get in the basic position, but if you find a spot that's difficult, you're going to fix the problem in the mouth and work your way out from there, okay? All right, so we are going to do a combination now of, let's just really talk about positioning. We're going to get to this as we go through. Okay, so let's talk about the maxillary right. So let's go to page 2.
Page 2.
Have your pen or pencil handy. All right, so upper right. Tell me about your
Upper right.
basic patient position.
Aspects.
Supine. What does supine mean? Flat. Do any of you have your patient supine yet? Maybe Brian.
Maybe.
A little lower.
Probably.
Okay. And their maxillary occlusal plane, this is the ticket. Maxillary occlusal plane has to be perpendicular to the floor. So, if you have the little 95-year-old who has the dowager tongue, the little osteoporotic neck, then what do you know, you're going to have your patient's head in the pillow. You're not holding them back far enough not to, give them a stroke. But it's going to be a position of, a function of, can you get their maxillary occlusal plane perpendicular to the floor. Then, which direction are they going to face on the aspect score 2? Book says away. Okay, get your mirror, look in the mouth. Realistic retraction means you're going to use what surface of the mirror?
Back side. The front side of the
Front side of the mirror. It's fine, no worries, it's fine.
This is that.
Yes.
You don't do this?
So the face of the mirror is the one that's on the inside angle. So you need to use the face of the mirror facing the TV. Okay? You need realistic retraction so the commissure lip really can't go past the first molar. What position do you have to have the patient in to be able to see the difference?
Supine. Chin up.
Do they have to turn to their right or their left for you?
To the left, like away from me.
How far away?
A little bit.
Not too much.
Tiny bit, right? Okay, try to see the facial of the third molar with the face of the mirror.
With the face of the mirror.
With the face of the mirror. Try turning them towards you a little.
Oh,
Oh!
that's nice.
Now you can see, right?
Yeah.
If they're facing towards you a little bit. Let's get your light on.
Oh yeah.
Okay, so the book says away.
I know,
Slightly away. And so in the skills test, you took the patient's chin and you stuck on your left shoulder. And you're going to try to just make a peek through here, okay? And come sure of their big lids on the earlobe. So you can't do that on real people. And so you can't see in the face of the mirror. Try turning a little towards you. Okay, and remember you're going to use your gross motor and direct vision to get in there. And then you're going to, use your fine motor and indirect vision to be able to actually get into the spot where you need the scale. Okay, so when you say this
Like
now,
especially on the distal, you mean, like distal surface in the back.
in the
of
more
the-
posterior teeth.
Correct.
Okay, so for a third molar, I often have the patient turn a little slightly towards me. Okay, and then I have a fairly straight ahead for the molars, and then when I get to the premolars, you're going to shift somewhere second, first premolar to direct vision. Now I'm going to turn them slightly away. Okay, so see how the book are really generalizations. And of course, part of it is that the book says that extraoral fulcrums are advanced instrumentation. Right? So, while you're in there looking at those, say, second molar, tell me about what is the instrumentation zone?
At the third molar, you said? Or
Second molar.
Or the second molar.
What's the instrumentation zone? Do you remember that concept of the instrumentation zone?
That's a restore line angle? No? We restore. I don't remember that.
All right, that explains why I put that question in like 3 tests and it doesn't go well. Okay. All right, set down your instruments for a sec. Let's start by writing down the positioning for the patient. So, supine. I would say looking straight ahead. And I would say third molar slightly toward you.
Set the molar towards
A little towards you. And premolars is slightly away. And then where are you sitting? 9 o'clock usually.
Just to clarify.
Sometimes 9:30.
Just to clarify, so we're still looking at the face of the mirror.
Face of the mirror.
When we go to the premolars. Or,
Okay, when you go to the premolars, at some point you go extra oral or direct vision.
oh, right, you're right.
And then if you need to retract,
Yes.
you can use the face mirror to retract.
Trigger track. Okay.
No, that's right.
Okay?
So for patients.
Supine. And then mostly straight ahead. But third molar might be easier to
Instrumentation
turn
zone.
Slightly towards.
That's because,
Premolars might be better slightly away.
so it's better for molar to face us, just because you want us to face more, or?
Because you're looking at the face of your ear. And third molar can sometimes be looking up your corner. Okay. Now flip over to page, I should number these pages, page 3. Okay, instrumentation zone. Here's the thing is newbies. Remember in my order of instrumentation lecture, I had the big block face with the big blue there. And the concept was that developmentally you guys scale by time. If I just scale for 5 minutes on every spot, it'll be fine, right? So when you scale for 5 minutes on your partners, when you did your partner trophy, that wasn't very fun, right? And you may have the 20-minute surface and the 30 or 10-second surface, right? So don't over or under scale. So that's part of it. So scaling just where the calculus is. So what do you know? Don't scale through the junctional epithelium onto the bone. So that's the most obvious thing. And we don't have to go from the base of the pocket all the way up to the CEJ and run into the CEJ or fly out of the pocket. We want to do those short controlled strokes and just go where the deposits are and at the correct strength and angulation for it. So if your partner has 14 microbes in their mouth and that's it, right, you can practically explore and be done. You're going to instrument to disturb the biofilm, but you're going to do that light overlapping strokes that are somewhat longer. And yet you're going to, if they really only have subgingival plaque, stay subgingival, right? If you have the patient that has heavy calculus, then you're going to do those engaged, biting, fracturing, shaving strokes. And you're going to start at the base of the pocket and you're going to work your way out. But again, when you get supragingival, when the calculus stops, stop doing that. Right? Shift to something that's appropriate in this biofilm. Think about, and this is the picture on the upper right, where's the calculus? Is it supragingival only? And sub is only plaque. Is it partly subgingival? Is it, a big long sheet of calculus? Is it only a subgingival ledge? Wherever those deposits are, that's where you're going to put your effort. And if it's supragingival on the root surface, that's different than supragingival on the crown surface, right? Because you have to be really nice extra nice to those roots. So that's the idea, is you're going to be thinking about being appropriate everywhere that you're instrumenting. You're using the right instrument with the right force for the right amount of time. Okay. So when we're looking then at, let's go back to your page 2 positioning. When we're looking at the upper right, how about the aspects away from the upper right?
Aspect away. Upper right. Toward you?
So the aspect away. So we did the aspect towards you,
Okay.
which is what surfaces?
Aspect.
You're all right-handed. Facial.
Right.
So the aspect away is what?
Oh, it would be the lingual.
Yes.
So it would be toward you.
Towards you. How far towards you?
A lot? Would it be a lot?
What do you think?
It
I feel like it would be a lot.
No, I think if I'm looking in the back, just enough.
Just a little bit?
Just a little bit.
Just enough.
Because if you turn too far towards and you're doing extraoral, what happens to your fulcrum?
It.
It starts to fall away.
You have to do weird stuff with your wrist, right?
Oh,
Yeah, we set it.
You mean an indirect vision? Indirect vision.
Indirect vision. With what surface?
Away.
I'm sorry, with what surface of the mirror, I should say.
face.
Face
Face
wise.
of the mirror.
And chin up, right?
No, chin down, chin down.
Is it chin up?
Yeah, chin down.
For this guy, right?
Yeah. Just turn his just turn his head around.
Okay.
Chin down.
So, remember how you set on this sheet inside the mouth with your mirror hand? So if you're over like 11, 12 with your mirror fulcrum,
Yeah.
it's easier.
Over 11.
So modified pen grasp. Good. Get inside your mouth. There you go.
Okay.
And that's going to automatically help retract their lip up out of your way if you're inside your lip.
Is that just for the molars? Is that just for the molars?
Oh no, premolars too.
Oh, okay.
Okay, and then you're doing your indirect vision. You don't have the indirect vision down yet. Get out that practice page. Keep going. Pretty comfortable?
Yes.
All right. Sit there. And then really straighten your neck. There you go.
Okay.
Okay. Let's see where I put it on here. So for positioning, where am I? Oh, so when you have a sec, then flip back to page 1 for a second. So when we're here, we've talked a lot about patient and operator positioning, but don't forget your equipment. Okay? So several of us have realized with dismay that I don't know if any of the trays in our new old clinic, the bracket trays aren't adjustable up and down, which is frustrating, sorry. But don't forget to pull that tray close enough to you or push it out of your way so that you're able to move. And then your Mayo stand has got to be out of your way on the other side of this chair so that you can come around to 1 o'clock when you need to. Right? Like, but I need to plug this in and the water's on this side. Make the water go underneath all your suction arm and everything and get that Mayo stand out of your way. And then really good retraction and light position. But remember that you have the base of the chair to go up and down and the back to ankle, and adjust both of them as needed. So if you're tiny, you're gonna stand up more. If you're really tall, make sure the base is going up and down as you need to. You know, but I know Paula for sure knows that, oh my God, somebody just don't roll over. So So then stand up and deal with it. Okay, and then remember that the teeth you're currently instrumenting need to be at elbow height. How do you assess elbow height? Sitting tall in your chair, right in the back, adjusted correctly, and your legs adjusted, height adjusted, and then you're sitting upright. Don't do this to check. This to check. Right? That's going to be the correct height. It's the teeth scaling at that moment. And so you may be working at one section, and then as you're working through the quad, you get into the anterior section, and what do you know? Those teeth are in a different position. You might need to change the facial height-wise to adapt. Please, please, please adapt to the chair, not your back or neck. And then remember talking about centering the teeth you're working on, especially anterior. So if you're working on number 6, the patient's head's going to be in a different position than if you're working on number 11, right? So center the teeth you're working on. Okay. Now let's make more sense. Okay, so now you have your notes on the upper right, aspects towards, aspects away. Got it? Mm-hmm. All right, let's go to the upper left.
So for upper right, the collation's not 10, 11?
Yeah, aspects away,
Sorry, Brian.
10, 11. So some of you during skills tests would sit like at 11:30, too far. It scrunches up your wrist. So try that for a second. Let's go back to that upper right palatal for a second and think about palatal of the upper right for just a second. And that you're going to make sure that you're not sitting too far up towards their head, because you've got to keep your wrist in a good neutral position and be able to use the back of your hand on their side of their jaw. Okay, so I'm going to slightly call you out. Paula. You guys are going to nag each other about keeping your index fingers up. Oh. I'll work this right. Across from each other. You're doing the same thing. Yes. So, you don't want it up past right? Yes. You don't want it.
We're on the upper left, right?
Probably gonna go back and check that.
Upper right
Stay
palatal.
on the right one. We're still on the right?
Like upper right palatal, right?
Yeah, I think she said to do it wrong, to be kind of rigid.
It's correct. Ms. Lennon, are you having to do upper right palatal?
So upper right palatal, look at your seating position when you're really good extraoral. And think about, now go try to sit towards 12. What just happened?
My elbow.
Your elbow's out, your wrist is probably bent, and now you're kind of picking with finger pulling because you don't have that good fulcrum, right? So that, well, it's bad, okay? So don't swing to 10:30 already. Start at 10. That's usually the Okay, so let's make notes about that seating position for that. Now, at a certain point, usually first premolar, you'll go intraoral.
Neutral, right.
Okay, so for your operator operator seating position, you're gonna make your note on that palatal, that aspect away. That you're gonna sit 10 to 11, but lots of times it's more 10 than 11. And then as you get towards the anteriors more, the first premolar, lots of times you just switch over, that's intraoral instead of extraoral, because you run out of jaw.
Yeah.
And when you're practicing again on these typodonts, remember that the second and third molar are the most realistic angulation for extraoral fulcrum. Your real patient will just close a little bit for you, and you'll be able to do that second premolar.
I like the maxillary.
Remember me saying, oh, I know you love the mandible, but you're going to hate it later, and you're going to love the maxillary?
Yeah.
Because, oh my gosh.
The lower right linear.
Oh, it's the worst.
That's it right there.
Yes.
Every time. That's it.
Oh my
Really
gosh.
good.
Right? I told them, AJ and Sunshine are lefties. You just work with them all the time.
I would nurture that friendship.
You sit there and I'll sit there and quit. Right? I think I told you guys I had a friend in dental school who was lefty, and I assisted him sometimes, and we never had to leave our sides of the chair. Trophy.
Working in harmony.
Okay, good with our notes. We've got that down. Okay, so let's go upper left.
With boards. So aspects towards you.
So everybody look at me for a second. I'm going to talk about this. Just come on over, and we're going to have your ring finger and your pinky on the board of the mandible. So, get their face to hug. Coming over here now, you're going to be pulling towards you to hug. So, try that. And what's your patient position for the palatal side? So this one.
Away.
How far away?
A little.
A little.
Sounded like a lot, Trish.
Where's your mirror going to be?
Facing or like facing.
Face of the mirror is facing the teeth.
Yes.
Yeah.
Where's your fulcrum for your mirror going to be?
On the chin facing. Check. No.
Over 4 or
4, 5, 6 area.
okay.
Okay. So remember on the lingual of the column on the right, your mirror was over on 11, 12. And now you're going to come around and be 5, 6, 7. Yeah.
Did you put the face patients away or
Away.
like this?
Just a little bit.
Doesn't work. You should be like that. You won't get better?
Away. I did away. Just a little bit. Away. Oh man, I'm hungry. I'm always hungry. It's ridiculous. I can't just stop being hungry.
Okay. So you've got your mirror coming from the right side. Your handle's going to be on the right side. The mirror's going to be on the left side.
You know, almost low key. This position sometimes works, but is that bad?
It'll be better to be at
9? Okay. Well, that's better than position 11. Oh, okay, that's better.
repeat that again back here?
Hard part is this patient doesn't have a nose that they actually just breathe through. So what do you know? You can't like lay your hand on their nose in real life. So you're going to have your mirror come across. Okay. So you know on the typodont how you always just snuck around the distal of the third molar? And that works on the patient that doesn't have any gag reflex because they're not alive.
Yeah.
So typodonts are awesome, but they have limitations because they don't go whoop on you. So, if you're bordering mandible, just to keep the underneath the edge to work with your brakes. It's a long reach for this palatal, but on a real person, they're not going to be open so wide. And this will actually wind up being really comfortable for you. For this guy's the chin. Good.
Because we're wrapping around.
Working on a lingual or facial to freezing leg, drawing almost.
And we're
I know with the good one.
Get that space back.
How are you doing?
pretty good. Are we like cupping the chin or more like?
Yeah, it depends on whatever extra. But you see how comfortable you are in that position, you can
Yeah.
see.
That's a
and
weight
you've got stability.
Yeah.
Are you working already on those legs?
No.
You already doing that fast?
So I have a question. So for this part, oh yes, I can see. The patient should be away or who is
There you go.
not sitting on the for the facial? Or what are you doing? Facial, yes, not manual. Facial of
When you're done
the
exploring,
flat.
grab something to scale with. Okay.
Like this.
That's stuck from the chin.
Okay.
When you do this,
Okay.
see how you have to pull with your fingers to make it work?
Uh-huh.
And that's why you're flying off.
One more comfortable.
So really firm.
Okay.
See how you're lining up your thumb with your middle finger? That's also forcing you to finger flex.
Okay.
So where does it have to be? Yes. Okay. So you have these long fingers and strong hands. Take advantage of it.
Okay.
Yes.
Okay.
Good. And you're going to really focus holding this snug between your thumb and your pinky. Your whole hand's got to be locked together. This is nice and nice.
Okay.
See how it's locked up?
Yeah.
Good. And then when you sit here, let's come back to this guy. Feel how hug here. And then just rock.
Yeah, see that?
Wow. Wow.
You should have no problem using leverage. You're very strong.
Okay.
Okay?
Sarah's wanting to do facial or buckles.
We'll be there. Okay. So, is this making sense now? It's coming back to you.
I need to take a picture of my hand so I remember this.
I fully support future plans.
Okay.
Partner take a picture of you.
I'll do it and I'll just send it to you.
Oh, cool. Oh, perfect.
And so as you move up,
Over my shoulder, maybe?
I have a question.
One second.
Yeah, and then one more of the
Yes, dear.
and then move up towards the central. This one gets a lot more awkward.
Yes, it does. So a real person would actually close their mouth for you. But then somewhere like when you go first premolar, I go intraoral. And then the anterior sextans rules apply. And we're gonna get there.
Yeah.
Okay, from molar to premolar.
Yeah. Cool, thank you.
And then
Yeah, that's the way to do it.
Yeah.
I could switch to this. I could switch to this once I get to the premolar. Could I? How do you feel?
I would stay in the
I'm not
930. It'll be your premolars and your molars. To me, it seems more difficult to be in the 12 position to try to get that. See that? It's a practice with using the indirect.
Okay. Now, let's just say.
But we're looking at premolars, posteriors.
Oh, we are?
Molars,
Okay.
Yeah. Yeah. And then open your mirror as you go further back. You see?
Yes. When I fix the
Yeah.
Got it. Oh, yeah.
Yeah. That's your posteriors.
Okay.
You're really strong. You gotta get your big left arm. So like you wear yourself out. Nice.
Yeah, because I was gonna do it,
Okay.
I guess we
So.
Can you at least find out what the cost is, so that when we talk, we can give us
Which one did you use?
Yeah.
I've been using my Explorer because I've been just wanting to fine tune my Explorer and, you know, a lot of help with that. Are we looking for?
I think it's scheduled to 12.
I'm gonna freeze.
You're gonna turn into ice.
No, I'm burning so much calories right now just to stay warm. Like someone would be like, what did you do all day? I did a workout all morning.
Yeah.
Okay, so we're pretty happy on the molars, and then the more insured you get, the worse it is. Right? So this is, the issue is this person that you have can't close their mouth. And they open superficially wide. So practice mostly on the second and third molars. But let's really quick go to, if you have a universal curette in your hand, which most of you do, switch to the other universal curette right now. And now go to the nasal of the second premolar.
With the lum lemon.
This one you want us to use the Loma Linda?
If you were using the Columbia before.
Yeah.
Okay. If you've used the Columbia and the Loma Linda, go to your Langer 3/4. Okay. So then, usually your second premolar mesial, that's where I usually go intraoral.
Wait, Could you say that again?
Usually I'll go intraoral somewhere around that second or first premolar. First premolar for sure. But mesial of second sometimes feels better to you guys intraoral.
Are we keeping the patients still slightly north so we can away?
Slightly away.
Okay.
Yeah, so position slightly away. Okay, so if you're out on the face, I mean for border of the mandible, you were telescoped out. Now if we're going to go intraoral, what are you going to do?
You're gonna
Pull it in.
pull it
Choke
in.
up, right? Pull it in.
So your thumb and index finger go closer to the,
So your whole hand is going to,
oh, the whole hand will
yeah,
go.
whole hand. And you're still going to have your index finger and thumb cocked back to get good leverage. Now when you go intraoral, I don't know if you remember me saying this on that, say mesial of
Second.
12 or 13.
Right.
How important is it not to finger flex?
Important.
How important is it not to finger flex when you're doing this intraoral? Very, 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 because if you pull it with your fingers and you slip, where's your instrument tip going to go? He's only cheating a little because I just told him.
What did you say?
If you're doing finger pulling
Yeah.
and you slip, you will bury the tip of your instrument right here on your fulcrum finger. Don't ask me how I know.
How do you know?
We didn't have to have blood work back then because we were living in the fool's paradise, right? I have to say the only good thing to come out of the HIV epidemic is the fact that, oh, we actually wear gloves and take universal precautions. So, learn from my fail. Do not finger flex. Rock off your fulcrum. Your hands got to stay unified as one. Okay, so pretty comfortable there. Same seating position, same patient position. You just changed where your fulcrum was because that's how you can, when you think where does that handle have to be, you can't have your fulcrum way down near the angle of the jaw. You got to be in the mouth. Okay? So there's that example of figure out where that instrument will touch your teeth and then figure out where does that put the handle and where can I get a fulcrum on this handle somewhere. Okay. You got your notes done for your palatal of the upper left. Good. Let's go to the facial. Now what?
Towards.
Towards,
Facial.
how far?
A little bit.
A little bit. What side of the mirror?
The face.
The face of the mirror. Right?
It's like for everything on it.
Pretty much. Yeah, I kind of would like you guys to try out with the single-sided mirror instead of the double. But you'll think the back is the front when you start. Okay, so where's your fulcrum when you're on the molars?
Extra oral.
Extra oral, right? Same spot that you were on the palatal, right? Upper left facial. Okay, you're still going to have that pinky used as your brakes, but your main fulcrum is going to be your ring finger.
Here's the ring.
Okay, where's your mirror fulcrum?
Side of the cheek or back.
Kind of on the side of the cheek. If you are using your wrist on their forehead, you know, not so much.
Okay.
Right? You can, but it kind of freaks people out. And then you want to make sure that you are
It has a little bit of a problem. It's kind of malfunction.
sure. Who's got their screwdriver with them?
I think,
Have a mission for talk about it.
yeah.
I have it. Thank you, Sarah.
So, every time,
I believe so. Yeah.
See how it's not your way up?
Yeah.
Because right now you're actually
Yeah.
loose here. And if your jaw's not attached to your teeth, then you can't do it. Oh, and then you have this screw that's a mess.
Yeah, that's the one that's fucking tiring.
So in my,
Let me clarify this for me. We're not doing this facial. That's toward or are you doing that?
we're doing away.
Okay, so it'd be 10
Can you do me a favor? On the top of it, just to the left of my desk, in the bottom, there are some type-it-ons. Can you grab one of them and there and spring?
like this, bottom left.
Yeah, so just one of the old type-it-ons, bring the whole type-it-on, and we'll cannibalize it in a bit.
So take this one off.
Wait for now, just go ahead and keep it for a second. Okay. Fulcrum for the mirror, that's where it was. Fulcrum for your mirror. This one time when I probably, yes, I'm over on their cheekbone with my ring finger. Occasionally I'm just have my elbow kind of tucked into my side to hold it out there in space. Depends on where I am. Nice.
So cheekbone.
Cheekbone.
Okay.
So, try to turn the page a little too far towards you. See what that does to your fulcrum and your ability to see. Right.
My
Too
elbow.
much.
Yeah.
It's really hard. Now, get your mirror so you want to look at your third molar. Buckle. We're going to do the same thing you did on the right. Does it help if you turn straight ahead? Totally. Not going at all. Take a look. Or even very slightly away. Is that a little easier to see? Christina's nodding. See what you think?
Oh, that
So
back molar.
straight ahead, that last
Yeah.
molar.
Yeah.
A little bit
So
away.
you see better
Yeah.
if they're straight ahead compared to a little towards you.
Yes.
Yeah.
Okay, so there's another. Gosh. So,
All these mind tricks.
yeah, usually you put molars a little further.
Okay, so that's the one that you have to.
So remember how we looked over here where it said, that one says come away? Or put a third molar, actually, turn the whole forward. Okay, so this time it says turn the whole forward. Yeah. If you turn this a little right, once I get you see a little red. Okay.
Is that only for second and third molars?
Usually,
Okay.
first molar you can usually see if they're really straight ahead or slightly towards. And then for sure, when you get intraoral, if you do, mesial of the first premolar, straight ahead or slightly towards you.
Intraoral fulcrum for mesial of first premolar.
Yeah, medial first premolar. Straight ahead or slightly toward you. Intraoral fulcrum.
Okay.
Yeah.
I need to stretch for a minute. Which looks big.
Yeah.
Bless you.
Thank you.
Did Lucio, are you going?
I don't think so. I was going to up till this morning, but I need to work. I'm not saying.
Today? Are you going?
You going to?
I'm moving. I'm moving.
Who was gonna go? Preaching this weekend.
Have his grooves, but you did that.
Yes.
Go out looking fancy.
We're just there you go.
I don't understand why I talk about it.
Our hygienist better at skating than dentist.
Just,
But they have to worry about so many other things. And like we're like really bumming. Yeah. Really?
Whole bunch of things happening.
Oh yeah. Yeah. I know.
You can stop chasing your guy around.
Yeah, you're kind of.
Okay, so,
One.
happy campers? What's that?
The sign for the premolars, is it okay to use the back side of the mirror? On the buckle?
Yeah,
To retract them.
but remember it's an aspect away. I would use the front side of the mirror as much as possible so you're not craning your neck to see over there. But yeah, that could be one where the angle of the back will work. Okay,
oh yeah, that works.
yeah. Okay, so now, how are we feeling? Maxillary posteriors, we're good?
That's the posterior, yeah.
Maximum questions, yes.
Grudging not from Kevin, all right. Okay, let's go to the lower left.
Ooh. Semi-supine.
Semi-supine. So let's talk aspects towards you.
Some mirror goes directly over aspects toward you. Feature goes away. Slightly.
All right, so switch to a different instrument. Find something, especially if you're not sure. Something not sure of. If you haven't used your
Yeah,
liner
this is your
before,
time to get comfortable with those instruments. Take advantage of it.
While you guys are doing that, I'm going to talk about shoes. So if your shoes are woven, please get new ones. They have to be solid. They have to be fluid resistant. For protection. Picture that you just dropped your syringe with the needle attached. I want you to have a shoe that gives you a fighting chance of not having tears toes, okay? And then also you want to make sure that you're not, if somebody, is bleeding a lot and you go in there and you spray water and they choke and they turn over on the floor, that you're not going to get a bodily fluid bath. Okay. So, lower left, lingual. Semi-supine. behind. Which way is it going to turn for you? Away. On which tooth?
The number 2. I mean, not
On the molar.
molar side.
Okay. So we're good, we're comfortable. Now what side of the mirror are you going to be using?
The
The back, because we're gonna
retract.
extract the tongue.
Retracting your tongue, indirect light, indirect vision, back of the mirror, right? So your mirror handle's coming across, you're going to be fulcruming on your cheek, on your right cheek, to be able, with your mirror, because we're doing that lingual of the lower right.
Lingual of the lower
So you
right.
can make this tight, but loose enough to,
How do
We're on
you?
lower right.
so, lower right, lower left.
Oh, lower. Okay.
Sorry, I
Oh,
misspoke.
right. Okay.
So lower left, lingual, molars.
Okay.
You're going to have your handle coming to the right of your mirror, coming across their tongue. Lower left.
Away from me.
Across this way.
Oh yeah, we're using direct vision. Great.
You're moving your tongue out of the way so you need to look at right at it.
How's your patient? So far.
It's so cool, no. It's more, this was, yeah, I couldn't, it would just, fly away from me. So now I think I got it. I'm still doing it.
You have an unruly patient.
Right. I just, but just somehow, no, way too much. It just kind of falls
Oh,
over.
it's not stable. It's not being able to lock in.
No, I just tightened it out, but Miss Lennon had it for a little bit and it did fine. Because, no, now because I tightened it. I tightened it, I'm turning it around to get it to that point.
Okay, I have 2 takers for polls, practice polls for at home. Did anybody else turn in a poll or not take one initially that
Oh, I can
that you would like to take one back to your house? I fully support that.
it's like falling over her head.
Yeah, because it is unscrewed again. Yeah.
Should I just find a whole other system? How to do it?
And that's more stable.
I'm just gonna, I'm not gonna answer this one.
This is happening. Tightening that too much.
I did that. I just typed.
No, you don't.
Are you okay, Sarah? You got these bumps up again.
Yes.
Your little arms.
It's freezing here.
Here you go.
Thank you.
Do I have
You
goosebumps?
don't want it? Thank you so much.
No, I'm really not sweating today.
Thank you.
I'll try not to drip on y'all. Oh my God. That, oh. When all the students are too hot, it's not me.
Thank you.
You're welcome. I'm used to being the obese postmenopausal woman. I'm just hot. Actually, I was the skinny, not postmenopausal woman. I was also too hot. All the time. My Nana would have, power surges when she was 90. It's not a hot flash, it's power surge. And her younger sister was the one who was always cold. So at her 90th birthday weekend, oh my God, the battle of the thermostat. And Nana was not running around
Not you,
at
no.
that point. So she'd say, Trish, could you go and be a good girl and turn the air down for me? Okay, so with your molars, we're happy with molars, right?
Yeah.
Okay, now go to the premolars.
The one premolar.
The one premolar.
I like the laugh.
Did you lose an, okay, then we were also gonna get you a premolar for this guy.
Oh wait, but mine is naturally missing.
Thank you.
Oh, you got two premolars.
Oh, I do.
They're awesome.
Okay, premolars, not so comfy? What could make it easier? How could your patient help you?
If they,
Putting the chin down.
A little bit, maybe. What else?
Move the chair.
It's hard to stand up on this more.
So I would leave them still semi-supine, not too far upright. So if we leave the back of the chair kind of in the same position, what else can you move besides their supine or semi-supine? They're turned a little bit away from you right now. What's another option? Towards you. Try towards you.
Oh yeah.
with the non-dominant hand?
Patient towards you.
Okay.
Okay. So you were for the molars, you were bringing your mirror from the right side over to the left side.
Yeah.
Now, you can do your coming the left side of their mouth. And use the face of the mirror.
Yeah.
And see how if they go a little more supine, not totally supine, but a little more supine.
So supine towards
Now
it.
what's going to happen to your seating position?
11 o'clock?
11.
Follow your wrist around, right?
Yeah.
11 o'clock works nice, could be 12 almost. See how you kind of inch around? So you'll start at like 10, 30, and then you'll wind up eventually at the distal of the canine at 11:30. And then what do you know? You can just keep going. Distal at 23 is at, 12 o'clock.
Just keep going around.
Just keep going around.
Oh, so cool.
So,
It gets better. I'm not here.
okay, a little more supine, and then turn towards you.
So I'm just trying to critically think through this. Let's just say if I couldn't figure out the right seating position, if I could just say, where can I stand up? And then where is my wrist going? And then just move so I can stand up. And then just turn their face towards the
Yeah. Yes. So whichever way it works, that if you start on the outside and you go to the inside, me, my patient, sure.
Yeah.
But if that's not working,
Yeah.
think about, okay, where is this instrument going to sit?
Yes.
Right? So I'm going to move the patient and me until we can align somewhere that I can get a good fulcrum and not be standing on my head or, hanging out in space. And then it's going to be right on the stone. Yeah. So see how here, and then you can come this way and then turn back to this end. And he will like walk. Okay. What happened to where your light has to be?
Has to come over. Like,
Way above, right?
oh, yeah, way above, yeah.
We're treating the premolars like the anterior.
Like they're part of the anterior teeth,
Yeah.
right? And you're just going to make your patient move to their right to be able to get those two
Anteriors? Oh, okay.
patient to the right towards you. Right?
And then you go more
See how your
in.
wrist stays nice and straight. You're sitting, seated comfortably. You can see over their nose.
Yeah.
Just lay them a little flatter. Okay? So let's write that down. I
So,
think it's getting even colder in here.
so we lay him we lay them flatter as we go interior.
You can, yes, you can lay them a little more supine.
More supine.
Towards supine. They're still semi, but
Uh-huh.
a little more towards supine.
Okay.
So the initial population for the molars. Nine, 9:30.
How did we put the mirror?
Yeah. 9:30. Okay.
For the mirror for the molars, I missed it while I was trying to screw it up. Did you do this?
Okay, so you're looking down. So, wait, okay.
We're almost there, guys. Almost there.
Are you feeling a little bit warmer?
Oh, yeah. Yes. It helps.
She was using this on the heater.
Oh, yeah.
Try and touch it. It's nice and warm.
Yes,
Oh, yeah.
it won't burn you.
Right, do not touch the back, you will get
Yeah,
hurt.
back is so hot. I did a.
On clinic, you can just be a little, supposed to be up here, right? On clinic, don't use your cavity wipes on the hot lens, will break. Right, so we shouldn't have to wipe that down. If you have yuck on the plastic cover, yes, wipe it, but you might have, if you have to wipe it because it has a yuck on there, then a damp paper towel will get the haze off of it.
Sladen didn't better. So the chair, it has something here, all the handouts. We can't sit on the floor at all. I couldn't yesterday. There are a bunch of things here
So
that I have.
you'll have to move it out of the way. We'll work with you. Grab your instructor. Uh-huh. Sorry.
No, I didn't.
Oh, yes.
Like when we were in here yesterday. Colder than I am. I have a lot more.
Huh? Oh, you're right.
Sure.
So,
You know, when you get that like small
you're
kids.
supposed to.
Yeah, there's really no time to count.
Do you guys see the bins of disposable?
Oh, no!
All right,
No, sorry.
so,
It scared me.
facial of the lower left.
Facial of the lower left. So the toward you
Towards you.
a little bit.
How far towards you?
A good bit.
Pretty darn far towards you, okay?
Okay.
Especially molars.
Is that the same for the maxillary as well? It would be pretty similar toward you. It's just the mandibular.
Just the mandibular.
Okay.
So, pretty darn far towards you. Which way are you going to use your mirror?
Facing
the face of the mirror towards the teeth. So facial on the lower left.
Facial over left.
We gotta be pretty far towards you for the molars.
Chin down.
Oh, is it, yeah?
It depends. Do they have a third molar? How close is the ramus? You know how sometimes you can barely fit the face of the mirror towards the cheek, and you just kind of look over their nose and do direct vision, right? So, but if you can, try to use the face of your mirror. You'll be able to see those buckles sort of better. All right. Number one. Oh, Josh brought me presents. So, the biggest mistake that happens here is where you guys put your fulcrum, which is partly because you're right-handed and you're working on that left side that doesn't have a first molar. So you don't have a good place, it feels like, to actually be able to fulcrum, right? So if you are on the facial of the premolars, please stop that. Please. Where does your fulcrum need to be?
More towards the front.
And more standing.
First or second?
Standing up and up. First molar, second premolar. What part of the tooth are you going to be touching with your fulcrum finger? Incisal. Which cusp?
Mesial.
Mostly facial cusps, right?
Okay.
Because you need to be able to stand up, but you need to still be able to get your handle out from the facial. Okay, but if you are on the facials of those teeth, and the patient has saliva and you like to type it on, where your finger's going to wind up sliding to? You're going to wind up down in the vestibule, right? You're going to wind up really low. Standing up really tall, you should be able to see that your terminal shank is angled correctly. And that you're pushing your hand down to create some good fulcrum pressure to be able to get really good stability. There you go. And then don't bunch up. Good. There. So what's different with your stroke? How are you activating differently?
It's, yeah, more on the fulcrum.
Yes, we're actually using leverage. Okay. Anytime you start feeling finger pulling,
Yeah.
stop.
Okay. And then readjust.
Reassess.
Reassess.
Grasp, fulcrum.
Reassess.
Here's their cheek here. Okay. Right? So, see how you got to have them chin down enough, towards you enough. It's kind of medium, semi-decline. Depends on how tall you are.
Sorry. Feels good.
Okay, so it's down.
Okay,
Thank you.
good notes on that? Okay, remember when you're scaling, you're gonna be in a system, you already have the patient away from you, sorry, towards you, because you're doing an aspect away. Now you're gonna come to this right aspect away. Now, see how you and the patient are gonna be generally the same position? That you have them turned towards you, and in fact, pretty far towards, right?
Mm-hmm.
Okay. And now, for this guy, I'm going to sit about 10 usually. And I'm going to have him a little more supine.
A little more supine.
A little more supine. And remember, this is where I have my elbows sticking up in the air against all recommended ergonomics.
Mm-hmm.
And that's how I handle it.
Are you?
So I have the patient turn way towards me. I have them quite flat, so you can to do those linguals. Where's my mirror going to be?
Pulling the tongue back?
Pulling the tongue back, so I'm going to use what surface of the mirror to
Back,
look
the
into?
other side.
Back, yeah.
Back side of the mirror.
Okay, and then where you're going to set your fulcrum for your instrument.
On a canine?
Instrument.
Canine.
Okay,
Yeah.
so usually around the canine, right?
Yeah.
It's challenging.
Telescoping?
You have to telescope some. Okay, so.
Lower right.
Oh.
You three guys look at me for a sec. When you're intraoral on this side, here's the thing. You don't have to be on the side of the tip of your finger. Right? So I'll use the back of my hand. You don't have to be way up here. You can be in here on the teeth.
Oh, okay.
And then I use my pinky with my, chewed all my fingernails off when I was a kid, so I have a very short nail bed. Harder if you didn't do that to yourself. Really short fingernail. Do not bisect their papilla with the fingernail of your pinky, but you can kind of use it as breaks because you're still going to be on your ring finger. Trisha's got it. Look at that. Okay. Here you go.
Let's see how high she is up on the tooth so she can have the patella.
You do not have to do the way in your finger.
Lock yourself in.
So. Great. But see how if you're trying to sit in that position, you wind up having to try to lift your finger? Horrible. So you need to bring your hand around this way. So follow your elbows up. So look at this. You don't have to be here. So you can keep these guys totally together and then reach in further. Yeah. See how you have a long nail bed because you're not like me, you cheat your fingernails off. You gotta cut that. Sure. And you have to be careful not to kill this joint if you're trying to extend it. Let's bring one down this way. That up? Yeah. Good. And take your back. Nice.
I don't know if we're supposed to let you know or just leave the careers and dentistry. We don't know what to bring.
Oh, okay. We'll have to send the email. Here.
Do you want me to tell Miss Lee? I don't know.
I know we have considered So you're gonna bring a cassette, your techodonge, and a great attitude, because we're gonna be able to know what under.
Okay. So we don't need to sterilize these cassettes from today?
Yeah, techodont lab cassette. We're gonna be using some extra syringes. Make sure you keep track of which one is yours. Okay, so.
Can we take up the bathroom break? Thank you. I have to stand.
Thank you. Okay, so take a bathroom break, guys.
Especially being cold.
Thank you. Sure. Warm up. Just warm up a little bit.
Yeah, keep it on the card.
With this ice much really.
Oh, no. Oh, good.
Yeah, this part's not great, but it's getting over here in the flower. They can't do that.
Oh.
You want?
Sure, I'll take it.
Not
Oh.
here.
Oh, okay. That's okay. I could, I'll take it later.
Not in your pocket.
Okay.
It's gonna be a mess.
Oh,
I put it here.
oh, thanks, Sarah.
Not a good idea. I don't know.
Oh, actually, you can have it. Okay. So
we're just gonna hide this.
Oh, I can put it in. Oh,
For the
perfect. Okay, so I'm gonna use more of like this.
Yes, the
This side?
side of your finger
Okay,
instead of the end.
and then I want to fulcrum around the canine, or like right here.
Or you can even be over here for distals.
Okay.
Right?
All
And
right.
then, yep, and bring these guys back to get your leverage. Nice.
Okay. Cool.
And then get your toe down a little more. There you go. Okay.
Okay.
Good.
Okay.
Okay. So.
Okay.
Stay at least disengaged. And relax inside.
Okay.
Keep practicing. You're missing some of the basic concepts.
Okay.
Remember how I said it was so fast.
Yeah.
It's fast.
Yeah. Yeah.
Okay. You're more focused.
Okay.
Stay more on task.
Okay.
Thank you.
All right.
Keep
Yeah.
doing that.
Okay. Yeah. Definitely.
You got some catching up. Good.
Okay.
Because you're trying to muscle stuff.
Yeah. Yeah. Okay. And I also remember, I think I was, for that last scaling assessment, I think I had to really focus on getting an approximal subgingival.
Yeah. So take a look at that terminal shank.
Yeah.
and angling so that you're not to the tissue. And
Yeah.
it's partly because you're not using leverage, you're trying to pull. And that's making it wiggly.
Right.
And that's cause trauma that way.
Okay.
Okay.
Yeah.
So you're gonna potential trauma to the patient and definitely trauma to you
Okay.
because you're overworking.
Okay.
Okay.
Yeah.
So when you hit that sweet spot of, oh, this is the right angle to do everything at, right? Fulcrum, force, leverage.
Yeah.
It's just gonna be so much easier.
Yeah. Okay.
But you're still kind of in this stage,
Yeah, that's true.
which tells me beginner.
Okay. And then,
Senior,
right.
right? You guys
Yeah.
are nebulous in this part. Your
Yeah.
juniors kind of, but it's really the next 4 years, so
Yeah.
seniors,
Yeah. Okay.
right?
Okay.
So you just, when you find the right spot, it's just gonna be like, leverage. This is just so much less force,
Yeah.
directed correctly.
Okay. And then last question. So I know that when we go to the posterior.
Too far, and don't make it
Okay.
curly. There you go.
Okay, so it's more
There. And you're gonna feel pressure here
Yeah.
and pressure there.
Okay. Okay. And then for the posterior, it's
Thumb
more.
will be a little lower than your index finger, just a hair.
Okay. Okay. And then for the posteriors, it would be like this. And then for anterior, would I just
Okay,
kind of same
so
thing, but
it's-
just slide forward?
So, depends, yes, when you're intraoral, you're always gonna slide closer to the teeth, right?
Yeah. Yeah.
And extraoral, you'll telescope out more.
Right.
And then what is really different about anteriors is, are you doing a straight instrument, an anterior design instrument? In which case, your handle has to be more towards the face
Okay. For
or the
anterior.
facial,
Yeah.
but you can be a little handle away a little bit to get in the lingual.
Okay.
And the other thing will be bend this guy. So this part of your hand. So whichever this works in your head, either, let's get you back to this, either extend your ring finger out, if that works in your head, or think about bending this middle finger up
For the middle
to
finger.
get taller on your fulcrum. To
Oh.
stand up, like if you're on your anterior sickle,
Uh-huh.
you gotta stand up away from your fulcrum more.
Uh-huh.
Yeah.
So you would just bend your
So you-
middle finger
you-
just slightly?
I think it is that I'm sticking my ring finger out,
Oh,
but you're also bending your middle finger.
just so you could be taller
So you can be further away from your teeth, get tall,
to get tall. Okay.
okay?
Okay.
And remind me when we get to the anteriors, I need
Yeah.
to talk about that concept, okay?
Okay, sounds good. Thanks.
Oh wow, a lot of notes there, Brian.
Oh yeah, yeah. Thank you.
Oh, yeah. All right. And then the other thing is telling your friends to remember layers for here.
Yep. Let them post on
Yeah.
Facebook.
Man, oh man. Yeah, we can take a picture of you all huddled together.
Their ear masks and scarves.
1176 used to be this cold.
It is cold too.
Yeah.
People came out in parkas and scarves and hats to 1176.
I was saying that you're.
I was thinking of bringing a mini blanket.
A space heater.
Adrian brought a portable blue one. Yeah.
Little space heaters.
Oh, yeah.
These one are square. So you miss a good.
Okay. Let's see. We're at.
Surface for the land.
So we're at the lingual of the lower right. Is that lower
Right.
Go right.
lower right?
I didn't hear.
So are we happy with that weird fulcrum?
Oh, thank you. Yes.
You know, it's weird, but it's okay. Okay. So I have had in my life 2 patients who were hit by trains while they were in their car.
Hit by what?
Hit by a train
While they were in their car?
Yes.
That's horrible.
Why are we laughing?
It wasn't my fault they hit me that way. Right? So they could turn their head way to their left, and they could only go to midline. They could not turn to their right. I'm like, maybe they're hygienists. Okay, maybe not. So I actually, for some of them, would have them roll in the chair so I could get the lower right. But here's the thing. If you have a patient that has some neck issue and they cannot turn their head very far, you can have them roll their body if you have to. But also, the way to do this without your elbow way in the air and them turn way towards is to sit them up and raise the chair and stand. So if you want to try that, you could do that real quick.
Oh.
Or you could just write it down, either way.
Like how much up? Like sit up?
Like not fully upright,
Just a little more upright.
a little bit
Like
back from fully upright. Yeah.
Oh.
Where are you coming
For the lingual of the lower right. And then you're standing up
Oh.
Oh, you'd be like
at 8.
No, not like that. You gotta raise the patient.
But the patient sitting up and the chair up. Uh-huh.
so you're like looking down.
So let's try it. So you'll have to move your instruments a little further back on the tray so you can really get that thing up. So if you're very tall, you end up with this chair high enough. So you'll have that.
You good?
Is this roughly the height we're looking at? Okay.
I go back a little bit so you can see better.
Okay.
So,
So how are you going to tell how tall is tall enough?
Elbow.
Elbow height. That's the teeth you're working on, so. Bring them up. So Tricia, stand up.
It's as high as it goes.
Pretending I'm
You're good.
It's not gonna go higher than that, is it?
Yeah.
Oh, the other one, other button left, the other one.
There you go.
Okay.
How would you describe the tongue?
So, okay, maybe 8:30. Yeah. That.
Am I kind of reaching like this?
Huh? So,
Am I reaching, I'll reach like this, am I doing this?
what are you, so some of this is going to get your, okay. Okay, so now the mirror's weird.
Everything.
Mirror's kind of weird, but,
Yeah, it feels different at first because you're not used to standing up.
and then here's the other thing. The patient laid back really flat and way to their side works for me. Ms. Hayton is better at having the patient a little more straight ahead. I can't make that work for me, so go find her. If the way towards you or just standing up doesn't work. And she's middle ground on this, okay? Where do you sit usually?
Oh, when I do lower A or straight. Yeah. I can't do it straight. I gotta do it toward me.
She just usually has them slightly towards the...
I can't either. Where is she? What's her position? Same position?
So I'm like at 10 and she's more 9 or 8:30, I think. Yeah.
I can't. I'm back here and I turn toward me. I just feel like I'm more in control of it.
Yeah.
You alright? Yeah, I'm just tired.
Here, I'll show you something when we're done.
Thank you.
Remind me. You won't be able to do it yet, but I'll just show you. Okay, so how's that? You're looking happier.
I like it.
Okay.
I really like it.
Okay, you stood up before. Right?
Like right to you.
You have stood before to scale,
Oh.
right? So you're more comfortable with it.
On clinic? No.
Okay. Oh, you haven't yet?
I don't think so.
Oh, you need to start standing.
Nothing like this. I'm
Right?
a little more comfortable with it.
So here's the thing. It turns out when they've done studies, if you are standing, there's actually less pressure in your lower back than if you're sitting. So if you have back problems, stand up some more. Cumulative trauma means doing the same thing repetitive, right? Repetitive motions and force. So the more you change position, the less likely you are to have cumulative trauma disorder. All right. Premolars, you know, with your standing, same deal, you know, how we're moving our chair around the corner. And move the premolars and then you can be standing till 8 o'clock with their interiors, right?
Yeah, should I move
Right? Okay. Happy with the lingual lower right? Less unhappy? How about that? That's probably a more fair statement. Less unhappy.
Less unhappy. Basically,
Okay.
more active.
Okay. So now, aspects towards. It's that you're putting down on the reestablish the pedal.
Lift it up first.
So lift up the back of the chair. There you go.
Turn the head.
If that happens on clinic, sometimes that happens, I go, please don't set the chair down on the rheostat. Make sure you always have the foot pedal on the floor,
Yeah.
because the chair, if you put it on the base of the chair and you put the chair down, it can break the chair base. Okay, facial of the lower right.
Head away. Sit down.
How far?
Slightly.
Slightly away. Okay, so let's go to the molar. Either way. I'm doing better. Remember last quarter I couldn't stand up for this one. That's good. But they're doing that.
8 o'clock?
Okay.
Your light? Like right 9. I like it so much.
Lower right, 9 o'clock, yeah. Oh, sorry, we stole your chair. I joked.
You want to take this with you?
Everyone go.
That was a good one.
Take the little Linda.
So I worked in an office where we had many, many anxious patients. And so I was there, one of the longest standing people there. So I had many, many of the really hard patients. And the other gal who was very experienced was a little rough and already. So I had those, many of the ones who were very, very anxious. They made me very anxious. And of course they would find me and they're like, nobody else can come out. My husband said one day, you just get up there with your score and just actually, whoops, and thrust it through their soft palate and you won't have to see them again.
Oh my God.
Are you going to bail me out of jail? I thought of that occasionally when it was a little stress reliever. I had a patient who cried and crossed at me the whole time. I'm trying to be nice to you. You could try to be nice to me too. Yeah. All right. So, patient position on the facial of the lower right.
Away, a little bit away.
Supine or semi?
Should be semi-semi.
Semi. How semi?
Not really much.
Slight.
Pretty semi.
Like this?
Yeah.
Much?
Not very far towards supine.
Oh, are we sitting down?
Right, so don't go crazy, but if they're super far towards supine, you have them laid too far back, what's going to happen to your wrist? Right?
Your elbow.
Okay, so I walk through clinic and you're this, you know, come on. Make your patient sit up a little bit. If you're pleasingly petite, what do you know, and you're in the chair that doesn't go low enough, you'll be standing. Okay. Right? And you'll just make them a little, even more upright. And if you want to take a break from sitting, then what do you know? Sit them up more upright, raise the chair, stand up. Give your back a little break. Okay? And then, when you're on the molars, towards or away, which is working better for you? The book says what?
Away.
Away. Okay. Which side of the mirror are you using?
Front side. The face.
If you're using the back of the mirror, I'm not saying it's wrong. How far are you retracting the commissure of their lip?
Well,
Pretty significantly.
you know, it's like it can undo a lot, but is that realistic?
You can only go back about first molar.
Right.
That's
That's
it.
not very.
It's not what you want, it's what you can. Yeah, where you prefer to be really uncomfortable if you do that.
Right, but you know, this is what I'm experiencing. So, them a little either straight ahead or a little towards you.
For the third molar?
Right? Second molar, third molar. You may
It looks
actually
good.
need to turn a little towards you. Okay? And then it depends on what you can fit in there.
Oh, it's better.
As far as again, do they have a third molar? Is the coronary process coming up that Raymond's coming in your way? Sometimes you can barely get your mirror in there. Sometimes you just retract the tube the best you can and pray you can see direct vision. Right? And so direct vision, you absolutely would have to have them a little towards you. So molars, I'm going to say straight ahead.
Molars straight ahead.
Okay, now let's hop to the premolars, and what do you think? Maybe first molar to premolars. Now what works better?
First molar to premolar.
A little away.
Yeah.
So not terribly far, just a little. And this is where I will do direct vision, right?
Yeah.
And this is why we kind of
like
start
direct
there.
vision.
Because you like direct vision,
Comfortable.
right? And you like kind of, we start on the lower right because it's the intraoral, and the teeth are standing up kind of straight.
Oh, yeah.
Okay, so slightly away, and then at some point, because right now you're sitting in what position?
9 o'clock.
When you get to the first premolar, where do you want to be?
8.
Yeah.
My favorite.
First premolar is 8.
Okay. So that's pretty familiar. Feeling good, yes? Mm-hmm. All right. So let's make notes about where you want to sit for sure for the facial of the molars.
Facial of the molars.
At 9 o'clock, we're gonna sit at 9 o'clock and have them
And
a
your
little
patient position too.
straight ahead, a little bit forward.
What's second and third molars?
Second and third molars might actually be better towards you a little bit.
Yeah. And then once you get to the first molar, you turn it a little bit away.
A little bit away. Okay? So make those notes.
This side, yeah.
Thank you. You're welcome.
We didn't even eat your lunch, Brian.
Ooh. I might wait till 5 and then eat a bunch. Or I'll probably eat like a snack. Is that weird? Okay, maybe I'll eat. Okay, you're right. I'll eat a salad. I'm trying to get back into it.
So, how are you feeling about the Gracies?
Yeah, pretty good.
What's happening with Gracies? And we got you your 3-4. Okay.
Yeah.
Any other instruments? Sickles, you're okay?
Yeah.
Not posterior. Gracies for back, mini for the front.
Mini you're going to use for line angles. So let's do that really quick. Let's go back to the lingual of the lower right.
Lingual.
And let's go to the distal lingual of 29. And grab a mini 13-14. Okay, so remember how we talked last quarter about we hate premolars because they're so round and skinny? And that the whole idea of, so facial and lingual we mostly do oblique strokes, except not premolars. Interproximal we do vertical strokes, premolars we do vertical strokes. Otherwise you fall off the tooth and you fall off. Without conversation. My dental student compadres over there, love you all. We have this lab reserved. I'm happy to share, but right now, because I'm trying to talk, I just need it really quiet. Sorry. Thank you so much. No worries. And so, you know, grinder. Thank you. Okay. So vertical on the premolars, right? But still, line angles on premolars especially are, right? So, sitting at 8:30, which is turned towards you. Remember how we said you can get your ring finger in there further, use your pinky as your braid, all that stuff we did. Vertical strokes on the distal lingual line angle at 29 with your mini Gracie 13-14. Okay, so here's the thing on the lingual, the lower right. If you're doing that turn way on the right ear, remember that you're looking between the back of your right hand and the front of your left hand. So between your mirror and your instrument. Does that make sense? So you have to look over the back of your right hand, so they have to be turned far enough towards you to see over the back of your right hand.
Okay, Miss Lennon, right over here.
Yeah. You're saying.
And your leg's got to be really tall, and you're going to look over the back of your hand.
25-minute mark, guys.
So my fulcrum for over that side is usually maxillary left with my mirror fulcrum.
Maxillary left. Oh,
Got it?
And you're maybe fulcruming on your canyon, like your.
She said that
You're going to be fulcrumed on your inside. Okay. So, whatever you want to happen on the blade, the toe of your blade, if you want it to go towards the facial, then your handle has to go towards the lingual of your scaler, okay? And that means that you have to move your fulcrum. You can't be stuck on the first molar trying to scale the distal of the second, You cannot be stuck on the first premolar with your fulcrum when you're trying to scale the distal of the second premolar. Your fulcrum right now should be on tooth number 25, maybe 26. Okay, good. And that's where, you don't necessarily have to be right near the end of your finger. You can be further up your finger towards the first knuckle.
How are you doing?
I think it's starting to feel better. Yeah.
There. Better? Good. Same thing with the other. Really bring it around. Yep. There you go.
this?
You can.
Okay.
Yep. That way. Right? And then there you go. Okay? Good, okay. So, these are great, the minis. Any place you need to do a little tight spot, just the line angle's awesome. Vertical strokes, okay? All right, let's do mandibular interior.
Mandibular.
And you got your mini 13, 14. Okay? Aspect towards us, you're gonna sit where? 8 o'clock. How upright is this patient here?
Straight ahead. Semi-supine.
How semi?
Very semi-supine.
But chin down.
Chin way down. Pretty upright, right? Please. Because again, I'll be walking through clinic and I come by and you're sitting here like this. When you want to go learn your teeth?
Yes.
Hey? No?
Yes.
Okay, so if your chair will not go low enough, stand up. Get the patient sitting way upright. And you'll be able to actually see and not be looking like Quasimodo. Okay?
How we
You do
can
not want to look like Quasimodo.
how we can extract their lower lid when you're working with the cabochon. From the back, the lid it's
So,
not so.
so here's the thing. Everybody come over here for a second. When I'm working on the lower anterior teeth, where am I going to fulcrum? On the incisors or first molars. So what usually happens to their lip just now? Tends to be down a little bit. Now, have I thought I just really put my heel on my lip? Right? Possibly another way. Same thing will run this side. I'm going to be on the teeth, try to hold it down.
Get in and see.
Will it always
Get in
work?
and
Not
see.
necessarily. So, getting your index finger in there helps. They want to inhale the or is that to do it?
Yes, yeah, it hurts.
Or be on the bottom of your feet. That's so what maybe that. Right. So I am always going to try to do fulcrum on either side to try to get the lip down. I have had to do like this before. It can be really tough. Okay. So extraoral fulcrums we talked about. You have to telescope out more. Intraoral, we're going to be closer. Now, anterior versus posterior. So come on back to your chair. And let's talk about that.
Interior.
Anterior versus posterior.
Let's quick pick up your Nevi 4 and your anterior length. Okay, so if you are doing surfaces towards you, we said 8 o'clock. So let's do surfaces towards you on the mandibular anterior. With your Nevi 4. Okay, so Nevi 4. So this one you figured out, oh, I can go from the molars all the way to the midline at least, right? And we like this because why? Okay, well, we need to talk about sharpening.
You don't need to change it.
You don't have to change. What else? What's the difference between that and the, yes, this extra bend compared to your M6, right?
Yeah.
What do you like about the Nevi Forbes compared to the M6 with that bend?
You don't really have to adjust your hand, like,
Right? You don't have to adjust your hand so much.
straight.
It kind of moves your hand out of the way of your vision. Okay, so now let's pick up, and it's a pretty consistent grasp and fulcrum from the posterior all the way to the anterior. Okay, now let's pick up your M6. To be able to get a good fulcrum, what did you just have to change with your grasp? And fulcrum.
Oh, is it the middle finger?
Get more upright. You have to really stand your wrist up, right?
Right.
You may or may not be able to, get a good fulcrum if you have your middle finger bent. Sometimes you have to bend your middle finger to stand up enough.
That's right.
Right? And where is your ring finger touching the tip for your fulcrum?
It's like on
Right on the tip,
the
right?
tip of the inside of the leg.
This is where you always go, ow, Miss Glennon, you're killing me, right? Because it's right at the end of your finger. Now, it may be the best instrument for a spot. So let's switch to the Langer end real quick. You may need some Langer work on that, right? And so this is nice for some line angles or a really deep interproximal crater on the anterior teeth that you got a piece of subcalculus on the mandibular. Okay, so this is a really standing up anterior fulcrum, intraoral, end of your fingertip, versus that Nevi 4, which is more the side of your ring finger. Okay, so that's part of the difference. You don't have to have quite as much pressure, I think, on your fulcrum when you're a little off the top of your finger. Okay. If you're going to do surfaces away, where are you going to sit? And what are you going to change as far as your patient position? Or supine, right? Because now you have to see over their nose and their upper lip. Lovely. And we say 12 o'clock, but where are you going to really sit? 11 to 1, somewhere in there, right? Because we're going to move our position the way we need to have our wrist in neutral. And what is your patient going to do for you? Not too far down. What else? So picture scaling from the distal lingual of 22 over to the mesial lingual of 27. They're going to turn. So that phrase, center the teeth you're working on, is to remind yourself to make the patient move for you. Right? So, go back to page 1, at the very bottom. Center the teeth you're working on, that's what I mean. Make that patient turn right and left so that you can keep your wrist in a neutral position. And don't forget you got your wheels. And this is really on these anteriors where Mrs. Friesen would say, don't forget that your wrist is attached to your hanger. Your hand is attached to the wrist. Okay, how are we feeling about maxillary anteriors? We're good?
We love those.
Same ideas, right? Now you got to make them really, really flat if you're doing the surfaces away from you. Definitely supine. And then you might even stick them a slightly into the lumbar, but they got to be chin up Usually our palatal is the hard part, right? For surfaces towards you. But 8 o'clock, surfaces towards you. Let's do that real quick. On maxillary interiors.
Yep.
To be able to see the lingual of 11, which way is your patient going to turn?
Away from me.
Away. Remember, you're going to do away. You're going to be semi-interior, secondary, maxillary, anterior, chin way up.
Chin way up.
Have a new music video song.
Yeah.
Yep.
Nice.
I don't have all the words for it.
You're gonna have to sing.
Okay, so palatal surfaces towards you, the patient is going to turn away.
Palatal surfaces. Or which one?
Palatal, maxillary, palatal surfaces. So
Okay.
11, 10, 9.
Yeah. Mm-hmm.
Yeah. And then, like distal lingual of 8.
Yeah. Mm-hmm.
Okay. So, tell your next group comes slightly dehydrated. Fewer breaks. Okay. Now that we have the patient laying flat, let's go back to pick up your mini Gracie, either mini Gracie. And look at page 3. So remember I had that whole page of reinforceable crumbs from last quarter's lab? Mm-hmm. Okay, this is just remember to put that back in your brain. Okay, so let's go real quick with our mini Gracie to the palatal of the upper left.
Palatal.
So remember, this is going to be your hanging onto your mirror. You stick your index finger out of your mirror hand, and you reach across. Remember that? And you're sitting at 9 o'clock.
Where are we going?
So palatal upper left. And then you're going to hang onto your mirror and yeah. And where's your finger going to touch? Okay, so when you're reaching across with your index finger to do the reinforced fulcrum, if you're doing posterior, if you're doing a distal, that's the word I meant. Then you're going to be like the picture I put in there because it's the hardest position to be in. Point. Somewhere across here. Hang on there.
Oh.
There, right? Okay. So if you look at that picture, my finger's coming up and touching the shank of the instrument.
Okay. Yeah.
What part of the shank?
The functional, or the
Yes, the upper shank, not the lower
upper
shank.
Yeah.
So you might need to sit a little closer to 8:30. But you still want your knee, you still want to straddle the chair. So you might have to scooch to your right a little bit to get your wrist to work. Remember that?
I remember that. Yes.
Coming back to me. Okay, so the deal is you're going to be on the end of the handle or the beginning of the shank. And you want to be pushing, if you're doing a distal, you want to be lifting slightly.
So we're pushing up with our finger,
Well,
with
if
this
you're
finger.
She said if you're doing this, push up. If you're doing mesial, push it down.
Just
What's it
depends
doing?
on which side you're on.
So if I'm on the mesial, I push down.
So that way,
Oh,
distal. There you go.
oh, and then
Feel.
distal. Okay.
Feel that?
Oh yeah. Okay.
So here, I would push it down. Basically, stabilize it.
Yes.
Okay. If you're struggling with the index finger reaching up underneath for the distal, pick up something that you can scale the mesial. And just do the little finger face down. And remember for this we're doing reinforcement for control and stability, not power. Right? This is not hulking out, it's to be more control. So please be cautious with this. Get with somebody who knows how to do it. Not all of your faculty do this. It's not just me. Mrs. Lewis can help you with this. Other people can help you with this.
I've done this in private practice. I've done this one too. I like it.
So, but just really slow down. And you got to stay on the teeth. You got to stay on your primary fulcrum, and you want this to be super controlled. So now, if you're doing a mesial, remember you're going to do, instead of this palm up, with your left hand, you'll put your palm down. You'll reach across, and do better with that.
I really like this.
Oh, here you go. There we go. Those pictures. Okay? So see how I'm not on the terminal shank. I'm on that, just right near the end of the handle. Because if you push on your terminal shank, what happens?
It'll bend.
Because it's bent, it's going to make it more squirrely, not less squirrely. Right? And it'll be scary. Okay. So let's back up. So there's your conventional extraoral, right? Here's your reinforced, same right-handed fulcrum. It's just my left hand is helping. Brian, much better. Feels good? Good.
Yeah.
Okay. Dominant side. Palatal. Turning the patient towards you. You remember how we did the Fantastic Four? We folded over our fingers. And made that little V between our index finger and our thumb. And Ms. Withers said something about the K-pop group. I don't know that song. Maybe y'all.
Oh, that Korean.
Yeah.
Yeah. They do that little
Like
thing.
whatever makes sense to you.
Yeah.
Right? So again, you're going to hang out your mirror, but you're just going to cross over your finger and your thumb. And you're going to add this to your conventional fulcrum. And this one, you really got to get your patient's chin up. You just have to lean over a little bit. And we talked about leaning from your hips. There we go. Okay. Crossed over. Conventional extra long.
Turn forward. Okay. And then lean over a little bit.
From your hips, right, and then we'll make it a little taller.
And then
So-
I'm pushing against.
And you're just gonna, remember, set this,
Oh,
right, so your index finger is gonna be resting, the pad of your index finger on number 30.
Ready?
There.
This one. Should be over. I hope you will.
I knew it too.
so we're using the thumb for stability. The thumb. Okay.
Very good. Okay.
So, something like this, but
Yep. And so bend this knuckle a little more. And don't lose your primary focal point, which is right in.
so I'm just confused. Oh, okay. I thought we were doing buckle.
Nope.
Because I'm like, how do I see
That has to be.
Okay.
So
Okay, so do you notice you have to have your patient sitting a little higher and really chin up for this to work?
Am I doing this right this time?
There you go, feel it?
Yeah.
And then this is going to be in There you go.
so we're pressing down with our thumb, right?
So you're actually just, it's a more of a rest
A rest. Okay.
to control the handle.
Okay.
Now, you're using a mini, so your strokes are going which direction?
A vertical.
Vertical, right? Vertical strokes. So line angle. So you know how you're trying to get the line angle, just the line angle on the towel? Ah, right? And so this will fit, yes. And vertical strokes will keep you from slipping off and sliding around and lacerating your ankle or potentially your martial jeans. Oh, like I was saying, we'll go 14 and generally. We all have done that sometime in our life. We're trying to move you past it too. Okay, so we got that back in your head. Good. And then, all right, we're going to just really quickly do. Sorry, now I'm keeping you over now. I totally get that I'm keeping you over. So this one, we are not doing. Just don't do that. We'll see if I get to it. It's perfect. Okay, let's sit your patient up really quick. Fairly tall. Still with your mini, 13-14. Sit or stand at 8 o'clock. Might be easier to stand. So again, we're doing minis. So what's our stroke on this?
Vertical.
Vertical strokes. Okay, so take a look at our pictures. Standing up, 8 o'clock, patient sitting upright. What is Ms. Lee's left hand doing?
Like sitting on a finger like this?
Yes. So she is pointing with her left hand. So same idea, hold your mirror in your left hand in those 3 fingers. And then you're going to set your index finger, you set the pad of your index finger on your first premolar, 21, and you're going to scale the distal lingual up 20.
Just a little.
So you know how it's hard to get tall enough on your fulcrum to get down into the distal there? So you're going to reach across from there. You have to reach across from this side.
So.
Yep. Reaching across here. And then setting, so other end.
Yep.
So we're doing the disc
Yep.
of 20?
Distal lingual at 20.
So I'm fulcruming on my finger.
Okay, so limitations. What are you having trouble with?
Visibility.
Right? So you can be very challenging. You can move your finger over to say 22 and scale the distal of 20.
And it's just that lining.
Yes. How's that? Oh, that's better. Okay, so challenging. If they have, you know, the whale tongue thing, it's going to be challenging. But easier to get taller. Yeah. All right, now come to 12 o'clock. Sitting or standing, picture on the lower, or picture on the right hand side. They have to be low enough that you can see over their head. So you have to lay it back some. What finger is this clinician using the fulcrum off of now? Their thumb, right? So take your thumb and set it on the lower anterior teeth. So, has anybody had the patient who has tons of recession on the lower anteriors?
Yes.
And you can barely get in there with your longer shank instruments to get down into the pocket, right?
My neck was bending in
Yes.
the mouth.
Yep. And so this longer shank, this mini, is great at being able to reach down in there. It's a little awkward because you have to bring your thumb around out of your way. But that will help get you down into those deeper spots. So you'll be sitting at 12, standing at 12, and you're reaching around.
Fulcruming on your thumb.
Fulcruming on your thumb. So your thumb's going to come over this side, and you're going to reach this far side. Okay? Okay, see how you have to bring your wrist curve to make sure that you're not scaling forward your thumb. Okay. It's in your brain, kind of. Okay. So now let's lay your patient down again. And we're going to try this other finger on finger thing.
72 fine.
So So supine. I know the picture looks similar. So lay them really flat. This is one that you can use looking from the buckle. But see how the operator is retracting the lip and also has their index finger of their left hand palm away from them on the occlusal of the second premolar, and they're scaling the first premolar. I'm sorry, they're on the first molar and they're scaling the, where are we? They're on the first molar. Okay, that's kind of a stretch. I would like to be on the first molar and do the meso of the second premolar. So number 3 for your fulcrum and number 4 for scaling. So that left-hand picture. The left-hand picture.
Oh, okay.
We're fulcruming on our finger.
Sitting at 9. Now, this would be better for mesial with 11, 12, or universal.
Yep, thank you.
Is that helping? Here we go. There you go.
And that's just because the shake is so long.
For some people, it's just more comfortable to be on there. It makes things get taller. Okay, so not my favorite thing, but might come in handy.
It's to be familiar with it.
Right?
Yep.
All right. Food for thought.
At least you have the exposure, right?
Okay. Let's try one more thing. Okay. Where's Ms. Lee sitting? Two. Yep. So on the day when extra oral is not working for you, which it should, I would work primarily on extra oral. But on premolars, so get your mini again, stick the patient's chin in the air, sit at 2.
Sit at 2.
Pretend it's the lower right. Right? We just turn the maxilla into a mandible.
Oh. Kind of weird.
Okay.
Decided I'm confused.
So face it.
Face the other way?
And like stand them on their head. So stick your knees to your left. There you go. And stick that patient's chin in the air.
It looks like a mandible.
Oh.
Okay?
Further posterior, get on the molars. Yep. She needs to adjust this.
To the left.
Yeah, sit like that. There you go. Now get in there on those molars. Go to do the distal.
Got it.
Okay?
Yep, there you go. Yep, got it.
All right. Whew. Once you get past the concept, it's easy, right? Like, what? You want? What? Okay. That's actually one of the easier things. All right. Here's, I'm gonna have you all take a break for a second. Actually, do you need to write any of this stuff down that we just did?
Yes.
Okay, do that real quick. Now I'm trying to get Jack lunch here.
Can we do something like this for here too? This is good. It's very nice sitting
So,
here.
how actually, right?
Yes.
Yes. And stand over here.
Yes. Okay. Back to 2 o'clock.
Right, but I'm saying, work first on your extra-oral profile. Because that's what you do. All right, you're set.
What was the last one? What was it called? Last one you just did about
There was
the
it's your alternate, alternate patient position.
Okay.
So who's coming back to teach? You have to have the Zen of the way. By the time you're teaching, it might be thinking at. Next slide. Okay. Okay, so this cross arch thing, so when we talked about to get around that distal line angle, lower right when it goes the worst, and having more cross arch is important to be able to get the toe to go around that distal angle corner, right? Okay, here's the other cross arch thing. I'm going to steal your stuff. No? Okay. Oh, is this not reserved? Okay. So, in the old days, not dinosaurs, but mastodons, we had regular Gracies. Okay, we had conventional Gracies. We were trying to use these that have this 5mm shank in 7 and 8mm pockets. Right? And the really long blade. And the pocket ice cream cone shape. Try to get it here, right? So, vertical strokes only got us so far because that worked nicely around this EJ and on the root trunk, but on the roots not so good. Okay? Okay. Here's what we did to try to get into the base of the sixes, sevens, is instead of vertical strokes, we would do toe down horizontal, oblique, or horizontal stroke. Okay? So, with these guys, then get some good indirect vision and come wave will get into that distal concavity. Okay? Now, what's the scary part about this? Right? So where's my mirror? Okay? So, this will be a process. I'm going to tell you this, and you're going to have to work on this, because this is not go upstairs and do this. So if I want to get the distal of this more, I probably still have my mirror back there in the cheek. And now you can kind of look across and do that. I'm using that for T14. Okay. So I'm using the one that you use for the palatal side and bringing it across. That is one. Alright. If I'm going to do this one doesn't work so much when you just run the I would be doing this guy, bringing my hand out. And again, I would have my mirror in the cheek. And I would either come from here, do a little bit across, super controlled, don't fly around like that. Super controlled. I might turn them a little further and have my mirror far enough this way. But I can still, try most of the time. I'm real experienced, so I'm comfortable doing this. But I would have you guys always have the mirror in the cheek, because if you slide, I want you hitting the mirror.
So, are you doing vertical?
I'm doing more horizontal or oblique strokes. Right? So it's not this, straight this way. It's coming out from their face. Okay? So this is coming attraction. Okay. There's that. We'll work on it later in lab, but start practicing at home on your techniques. Okay.
They don't open that much.
They don't open that much. Right. So
I rarely see the last.
we'll work on that. Okay. Now, here's something that is easier that you can we've had the person who's had impacted third molars and now they have big pockets going in his molar second molars. Have you had that patient yet? Yeah. Okay. Right. And there's pocket and bone. Right?
Yes, yes.
On both sides, and they have this crater across that distal. Okay. So, reaching across here and going palm down. This is the end I would use here. Only now I'm going to go 90 degrees. Okay? Now I'm going to reach across the distal. I'm now doing that double fulcrum thing that we did with the 15, 16, then 17, 18. And remember me saying the plane of the stroke, handle, finger, that's the direction your stroke's going. When I want to have it come vertical, I've got to be standing up. If I want it to come horizontal, I have to turn it over. Be very, very good. Well fulcrum. My thumb is pushing against the distal of the tooth right now. Right? And I'm doing a little short stroke. This is the one I want you to try today. This. Like that. These marks. Yes. Doing from.
It's down and kind of scooping towards you.
And you're doing a little short horizontal stroke.
That's blind, right?
No, this has the middle spike in it. The tongue has to be really retracted. You cannot do this blind.
How are you seeing it?
Because your patient will not have a middle spike in their tongue.
Oh, okay.
Okay. I mostly like the tongues, but oh my gosh. And then I also have done this as well. That's pretty challenging. But this one's good. Right? So try the ones that are towards you. Look at that. So 13, 14, patient really flat. If you want to come back for another. Work it out. They'll be sitting slightly upright. And you're going to sit at
50-foot here, coming in 3 cross.
So let's go to the distal of 17. And you're going to choose the end that would be the distal buckle. Okay, and now you're going to come fulcrum over on 26, 27. Palm down towards the patient's chin. You'll have your mirror coming to retract the tongue. So bring the mirror in. And you go toe pointing straight down the pocket. Okay, and real short. So you put your thumb against the distal.
Oh, wow, silence.
Yep. So it's the, I'm going to air quotes here, wrong end of the instrument,
Oh, it is.
right? Adapt to the buckle, but then play the stroke to vertical. And your elbow's going to be in the air a little bit, your right elbow. Tiny stroke. So, can you make a 1 to 2 millimeter stroke? That's the thing.
And I wouldn't use the mini for this, I'd use the standard one.
On the center. Okay.
My thumb is going to push against there.
There you go.
So, are we using more?
Okay. So again, this is more, think about moving to these more advanced things.
Are we using the toe more, or the?
So you're still on the side of the toe,
Okay.
okay? Food for thought. All right. Things to work on your own this summer. Okay, on the tape time. Files. How are we doing with the files? Yeah. Okay, same idea. So pick up your file, that would be your distal file. So one that you think of as the, it's going to fit right flat on the distal. I cannot tell you what number that is. I know it's in the paper.
Twelve, 13.
Good.
Yep.
And it's the number 12N. So is the distal one. So this horizontal thing that you just did, cross arch, that'll work with your files too. So there was a small method to the madness. Now, if you're struggling to go across arch, you can do the same palm down, say on the distal of 30, on the buckle. Make sense? So that whole palm down that you just did and dropping your hand down in the double fulcrum.
Extra oral?
So the same thing we just did with cross arch. Just let's get your other one. Like we just did with the 13, 14. Or you can also do okay? So let's come choke up a little bit and do this guy. Okay, so remember these horizontal strokes are great for CJ area. Okay, and then let's go to the distal of 31 and do vertical. So now you have to change your fulcrum to what? You had it laid down double fulcrum. So now to do vertical strokes, you're going to stand up, right? In a more conventional fulcrum.
I'm using the right.
Oh.
Am I using the right
Okay. So this distal file works nice on the mandibular, on the distal. I gotta say, I don't really use files in the neck, sorry, because I do more vertical strokes. But it's a possibility. I gotta say the mesial one, has anybody successfully adapted the mesial file to their mesial surfaces? Yeah, right? Yeah, okay. And then if you are going to, so the videotape of me using it horizontally, yes. Vertically, I have really struggled with. So go back to the files lecture, and there is a video posted in there with me doing a horizontal stroke.
for the mesial?
For the mesial. Okay, facial and lingual file. That's pretty straightforward, right? Vertical stroke, make it as flat as you can, go for it. Okay. When you're on the anterior teeth, the mesial and distal file you can use on the mesials and distals of those teeth, but it's then kind of surfaces towards and surfaces away. So look at the mandibular anterior really quick with the mesial distal file and just fold it up to it.
Wait, sorry. I'm confused.
Okay, everybody over here.
Can we use this?
Come on over here. So, get your mesial and distal file first. Okay, so if you think of surfaces towards, surfaces away, then you can use the distal, distal, mesial. can use it, however it fits in your hands. And then you can also use this guy somewhat on the lingual. Right, so that's right here as well, and there's a picture like this in the lecture on class. So this will work on palatal, even though it's a distal file. Okay, so that's what the notes in there about files, what surfaces would you zoom on. Use it where it works for you. Be thoughtful. That was the message for that part. Okay, y'all need to go. And have some food.
Yeah. So pretty much just. Thank you.
You're welcome.
He feels comfortable,
If
and
it-
you're not damaging
And you're not damaging tissue or yourself, right? Thank you so much for your patience. You were fabulous.
Thank
You're
you.
great. Okay, careers in dentistry. Monday. Be here early. We're going to give you time. I want to say it was 2:30 because we're starting at 3. Yes, okay. And that you're bringing a set, and you're bringing your Typodon. And we're going to do what we did do with you. I'm sorry because my brain was way too full. We're bringing cherries, and the students are going to inject cherries. So we're going to bring sharps containers, and you're going to try to avoid people impaling themselves and each other. Okay?
This Monday?
This Monday.
They don't get to inject each other.
We'll get the announcement out.
They should do it like us, where we just go right for it.
Well, I gotta say, normally I plan and bring cherries, and I just was. Yeah, I was just overwhelmed.
Yeah.
So apologies for that. But, you guys will be able to do that, and the reason we use cherries is they're small. It's summer, they're relatively cheap, and they have a pit.
And they have a
So
pit.
they can touch period.
Yes,
Oh.
And if they're red cherries, then you will see the positive aspiration and see the cherries. So that will.
And then,
Check it out first.
and then I'll ask him the anatomy of the cherry.
Right.
What nerve are you getting?
It's a universal. Yes.
What you gonna go get right now?
I don't know, anything.
Anything would work?
Anything. I just honestly
Yeah?
just need to find something with protein in it.
Okay. Yeah, you don't want to pass out or something.
I feel like my room is getting hot.
Oh, shoot. Okay.
Yep.
Okay. So what was this? What was the song that you said you
Have you heard the song Work From Home?
work from home? I could look it up if you want me to before we do sing it.
Make the patient work.
Make the patient work.
Yeah, you'll hear the song and you'll be like, oh, I get it.
Oh. If you want, I can record it for you. And
I gotta find the lyrics to the other parts, like,
Okay. You should record it and then, make a video.
You should make a video, yeah.
Yeah. That'd be pretty cool. Huh.
I think we can do a really cool video.
Oh, thank you.
Sure. Is that
Homework?
recording? It's
Yes.
going to be in the Facebook?
Oh yeah, I posted it on Facebook, but I can send it to you.
Thank you.
Yeah. First thing.
Thank you so much.
I know that That homework assignment was kind of confusing.
Yeah. I didn't know that Monday that we can. This guy should be sterilization or no?
Oh.
Just
We
bring a
don't.
cherry and
Yeah, you don't really, because we're not doing it on each other.
got it.
So, yeah.
So we'll have.
See ya.
Have a good weekend.
I'll get it for you right now.
Not that much perfect. Thank you so much.
Wow.
Thank you.
Starch and iron it.
Thank you so much.
Oh, my goodness. Yeah. All right.
That's funny.
I was just thinking, wow, I mean,